चलिए अस्सलाम वालेकुम, वेलकम एवरीबॉडी। हमारा जो ये वेबिनार हो रहा है क्रिटिकल केयर एस्पेक्ट्स ऑफ COVID-19, today is June 5, 2020. So first of all, I'd like to thank all the speakers who are volunteering their time and effort. And at the same time, I'd also like to welcome all attendees. ये program जो है, this is going to be recorded and it will be available on SKM website in about a week. अच्छा, कुछ ground rules. So there are CME credits for attending this program. You will get an e-certificate. If you have any questions or concerns, to symposium@skm.org.pk यहाँ पे आपने email करना है. Questions आप कैसे पूछ सकते हैं? So just text in your questions. मेरा ख्याल है live पूछने की facility इसमें नहीं है. So every speaker is given a certain amount of time. कुछ talks हमारी 10 मिनट की हैं, कुछ talks हमारी 15 मिनट की हैं. So what will happen is 3 minutes before the end of the talk, एक bell बजेगी just to remind the speaker कि time is about to be up. वो wrap up कर लें. And then आखिरी bell हम talk end पे कर लेंगे. Questions and answers will be at the end. And do give us your feedback. In order to get your e-certificate, feedback is necessary. Or this feedback and the e-certificate form will be available within for up to 48 hours after this event. तो उसके बाद हो सकता है ये available now. So don't delay this. दूसरा ये कि we will try to be on time. However, ये जो webinars and technology and all these things sometimes they're not under our control. तो सबसे पहले speaker को मैं invite करता हूँ, Dr. फैसल शमीम, critical care consultant at AKU, and I think he's also the fellowship director for the critical care program. And he will be giving us a talk on prone positioning in COVID-19. And we will have you online in Dr. Faisal in a few seconds.
Assalamualaikum, Shaul Khanam and Dr. Bilal and Dr. Rehan. Thank you for giving me this opportunity and honor to speak in this webinar, Critical Care Aspects of COVID-19. I'm Faisal Shamim, anesthetic and critical care consultant at AKU, and I'm going to talk about the prone positioning in COVID-19 patients. I have no actual or potential conflict of interest in relation to this program and presentation. And just a quick concept regarding the prone position and its effect on physiological effects on oxygenation. So how does prone position helps in oxygenation? So there are three mechanisms by prone position doing this. That is the reducing ventral and dorsal transpulmonary pressure difference. There is a reduced lung compression and there is improved lung perfusion. Now, the standing pressure of the lung is estimated by the transpulmonary pressure, which is the difference between the airway pressure and the pleural pressure. This standing pressure or the transpulmonary pressure, when a person supine, this transpulmonary ventral transpulmonary pressure exceeds the dorsal transpulmonary pressure, which results in the expansion and distension of the ventral alveoli. What happened is in ARDS, there is an exaggeration to the response. This response is exaggerated. And in acute respiratory distress syndrome, the ventral alveoli becomes over distended and the dorsal alveoli becomes the atelectatic, as you shown in this picture where the dorsal alveoli are atelectatic. What happened is when we turn the patient prone, it reduces the difference between the dorsal and the ventral transpulmonary pressure. What does it makes? It causes जी मैंने चेंज So in this picture you can see the in this picture you can see that the ventral and dorsal. जी बिलाल बोलें. Okay, assalamualaikum. Sorry, there is some trouble with the mic and my slide changer. So just again starting the very thankful to Dr. Bilal and Dr. Rehan and Shaukat Khanam for giving this opportunity. I'm going to talk about a prone position in critical care aspects in COVID-19 patients, and I'm an anesthetic and critical care consultant. I have no actual or potential conflict of interest in relation to this program and presentation. So how prone position makes an effect on oxygenation? So there are three mechanisms why a prone position does have a physiological effect on oxygenation. And when a person is supine, there is a transpulmonary pressure, which is a descending pressure, and the transpulmonary pressure is the difference between the airway pressure and pleural pressure. When a person is supine, the ventral transpulmonary pressure is extended or exceeded the dorsal transpulmonary pressure, and this leads to a significant exaggerated response in ARDS. What happened in ARDS that the ventral transpulmonary pressure is exceed, and that leads to over distension of the ventral alveoli, then the dorsal alveoli, which in this picture can see the dorsal alveoli has become atelectatic. What prone position offers is that prone position reduces the difference between the dorsal and ventral transpulmonary pressure, that leads to a homogeneous ventilation, that leads to a decrease in ventral alveolar overinflation, and that leads to dorsal alveolar collapse and recruitment of alveoli that had collapsed during the supine position. Now in ARDS, there is a substantial ventilation perfusion mismatch, and this blood flow, as we know that the blood flow and the alveolar collapse are both greatest in the dependent portions of the lung. When we make patients prone, the ventilation perfusion matching improves. This since previously the dependent lung continue to receive the majority of the blood flow as alveoli reopen, and while the newly dependent lung portions are continue to receive the minority of the blood flow, are alveoli to begin to collapse. With this table, we can also see the proposed mechanism from prone position and how we get a beneficial response from prone position. That there is an improved configuration between the lung and thorax. The heart is dependent. There is more homogeneous transpulmonary pressure gradient in ventrodorsal and cephalocaudal planes. So that leads to improved ventilation and distribution. Then there is a smaller volume of dependent lung. This will increase the FRC and decrease the shunt. The abdomen is unsupported. Now, what does it mean that abdomen is unsupported? When the patient is prone, the chest and the chest rib cage and the pelvis has come into the contact with the bed. That leads to the more expansion of the abdomen. Abdomen is free. So there is more secretion mobilization, there is improved bronchial drainage, there is improved ventilation. Again, there is an improved aerosol delivery, there is improved effect of aerosolized medications, and again that's lead to an ventilation improvement. And there is more homogeneous perfusion, which is less dependent perfusion, and improved ventilation perfusion mismatch. So this is a quick concept regarding the prone mechanism and the prone response. Now, we know there are at least 40 observational studies, there are trials, there are randomized controlled trials, there are systematic reviews from since 1974. All trials have shown mild to dramatic increase in oxygenation, and we know a large PROSEVA study which is published in New England Journal of Medicine in 2013, where it has shown a mortality benefit of the prone position in ARDS, and the number needed to treat was 6. So that causes that leads to an insight of prone position and its beneficial effects in ARDS. And the other beneficial effect of prone position is there are ventilator-free days were greater. So when it should be considered in ARDS, in PROSEVA trial, it has been recommended or suggested that when the PO2 FiO2 ratio is less than 150 and with a FiO2 of greater than 60% and a PEEP of greater than 5, it should be considered early in the course of the disease. How it started awake proning or repositioning in COVID-19 patients. I saw an interview of the Chinese anesthesiologist who was working in the Wuhan, and he himself affected by the coronavirus. And what he does, he started himself an awake proning and asked their critical care team to make him reposition and prone, which leads to a beneficial effect. So this was the first. I think this is the first article which shows a lower mortality of COVID-19 patients by early recognition and intervention. And this is the evidence base where the Jigsaw province, and this published in Intensive Care March 2020. What they do is they make the patients prone, and they have shown and they have seen that the early improvement comes from the prone position with the non-invasive ventilation. Caputo et al. Have again published a case series of 50 patients, and in this case series of 50 patients, the 36% require intubation, but 64% of the patients improved and avoided intubation. And what they have managed their patients with the strategy of ongoing positional rotation for 30 to 120 minute prone and right lateral, and then decubitus, and then upright, and then left lateral. So the advantages they have quoted in their study is that there is minimal cost, but there is a risk of delayed deterioration. Another evidence which has come in the JAMA, which is published online in May 15/20, there is a single center before and after study in 24 patients with hypoxemic respiratory failure and infiltrates on chest CT. The positioning started without changing the system for oxygen supply or FiO2. No change in if the patients are on NIV or if the patients are on FiO2 of whatever the FiO2, they don't change the system and they turn the position to prone or उन्होंने position change किया, and then they have seen that 4 patients did not tolerate more than 1 hour, but 6 out of 15 patients had mean increase of the PO2 greater than 20% from the baseline. Prone position has been combined with other techniques, and this has been seen as a major advantage when it is combined with a variety of additional techniques like prone positioning with room air, with low nasal flow nasal cannula, with high flow nasal cannula, with BiPAP CPAP via facial mask, with BiPAP CPAP via helmet interface. And there is a new evidence published on JAMA in JAMA 2015 of 2020. This is a one-day cross-sectional before and after study, and they have done this. They prone their patient outside the intensive care unit with non-invasive ventilation, and they found a similar advantages and similar beneficial effects on their patients with the prone position and prone. Again, a very small case series. There is early awake prone position, which is combined with high flow nasal oxygen therapy in severe COVID-19. This case series is published in Critical Care. Out of 79 patients, there are 10 patients they have declared severe, and out of these 10 severe patients, 5 were male and 5 were female. The imaging features were all same in those 10 patients, which is the ground glass opacification and consolidation. The baseline ratio of PF ratio was mostly less than 200. They have found when they turned their patients to prone, none of these 10 severe patients require intubation. The length of stay, hospital stay, is very much within a month, and they have good outcome and they all survived. Can we make some inferences from these small case series? Can we make some conclusions based on these small evidence? We know that the sample size is small. We know there are lack of control groups. We know there is findings cannot be generalized without confirmation in larger trials. The convenience sample with no randomization. But there are some conclusions that can be drawn cautiously. हम इस चीज से कुछ ना कुछ अखज़ कर सकते हैं, कुछ ना कुछ conclusion बना सकते हैं, and वो ये the most important conclusion is that many patients tolerate the awake prone position, and there is an improvement in oxygenation and decrease in respiratory rate occurred. Now, improvement in oxygenation during prone position, this has led to now the evidence is coming. There are more reports are coming that clinicians are not intubating patients with COVID-19 solely based on hypoxemia. We have seen some unusual pathology in this COVID-19, and we have seen patients that they are sitting with 70%, 80% of the oxygen saturation, comfortably talking, comfortably breathing, but they are not in any distress, but they have hypoxemia. So this prone position and this improvement on oxygenation can lead to, and which is a potentially good outcome, the improvement in oxygenation. So people are avoiding intubation in this percentage of population. The big question is can the prone position prevent intubation? Now this question is essential. We know although intubation is a medical decision, not a physiological state, but the more trials are coming, and to answer these questions that can prone position prevent intubation, there are 3 trials on clinicaltrials.gov which are registered for prone position, and these are, one is a physiological study and 2 are randomized controlled trials. and these are OptiProne, Approved Care, and COVID-Prone, and in which they are going to find out the answers with randomized controlled trials and more sophisticated statistics and more controlled trials to find out these answers of prone, awake, prone position, awake, prone repositioning, and its effect on larger population with COVID-19 population. Awake proning, when it should be considered, recent intensive care society guidance have come up, and they have seen that if there is an FiO2 of greater than 28% and or requiring a basic respiratory support, and you will consider and you will assess the patient that whether this patient has a prone position, has changed prone position, and can we ask the patient to turn on prone. So communicate and cooperate with procedure, rotate to front and adjust position independently, and there should be no anticipated airway issues. If that is perfect, then I'm leaving the contraindication and we should assess the patient to prone position, explain the procedure, ensure oxygen therapy, the pillows may be required, there is reverse Trendelenburg position may aid comfort, there is monitor oxygen saturation, and sedation must not be administered to facilitate proning. Continue with the proning process. If the deterioration, if the oxygen saturation is decreased, ensure oxygen is connected, there is an increase in inspired oxygen, the patient should change the position, and then there is a protocol by this protocol has been published, and this protocol has been followed by the intensive care society. There are different approaches to positional adjustment in COVID-19. Now, awake proning has also been somewhere are also being written as or being suggested as to say as awake repositioning. In terms of awake proning, awake repositioning, and the suggested position changes. This is the most suggested time position changes for patients undergoing conscious proning, that it should not be full 16 hours like we did in or we are doing in ARDS intubated patient for 16 hours proning. We should ask the patient to lie on prone on belly for 30 minutes to 2 hours, then 30 minutes to 2 hours for on the right lateral side, then 30 minutes to 2 hours for sitting up, then 30 minutes to 2 hours for left side, and the cycle goes on and assess the patient and assist the patient that the patient should be doing the changes in this position. There are some other equipments or some other pillows available. This is a pregnancy massage pillow which has a removable abdomen. This has been used by certain in a one center which did help the patients, and they removed their, and especially the patients with obese patients, they have really benefited from this this pillow. The other thing, the conventional pillows can be offered and can be used for making them prone or ask the patients to become repositioned. And the important thing is that the repositioning should be continued every 2 to 3 hours. Not in a conscious patient should not be prone for more than, say, for continuous proning is not advised for 16 hours. So in conclusion, awake proning or repositioning appears to be a safe, inexpensive, and versatile strategy which can be leveraged across a variety of different healthcare systems. Thank you very much. I'm done with my presentation.
Thank you, Dr. Faisal. That was very in-depth and very helpful. Especially the diagrams were each worth 1,000 words. Thank you. So next, I would like to invite Dr. Ehsan Waqar Khan. He's HOD of anesthesia here at Shaukat Khan Memorial Hospital. Oh, okay, thank you, Dr. Faisal. That was very much in depth and very much needed. Answered a lot of questions we had. Next, I'd like to invite Dr. Ehsan Waqar Khan. He will be discussing non-invasive ventilation in COVID-19. This talk is roughly for about 10 minutes, and we'll ring the bell after 7 minutes. Thank you.
Threatening plan.
Assalamu alaikum. My name is Ahsan Waqar Khan. I'm a consultant in anesthesia and critical care at Shaukat Khanam Hospital. So in the next 10 minutes, my job is to talk about non-invasive ventilation. I don't have a presentation. I'm just going to have a chat with you guys. First of all, my thanks to the organizing team for organizing this webinar, which is very much needed for our specialty. What I will be talking about is physiology around non-invasive ventilation, the present knowledge that we have about non-invasive ventilation vis-a-vis COVID-19, and the current practices that we have. And in the end, I will try to conclude what we are going to talk about. So physiology, just briefly. So what we are aiming to do with non-invasive ventilation is to increase the inspiratory flow rate. Once we've increased the inspiratory flow rate, the functional residual capacity increases by virtue of increase in volumes. And this helps in reduction of the VQ mismatch. Now, the VQ mismatch, as per our understanding of COVID-19, is twofold. One is a shunt physiology. The other one is the dead space ventilation. Shunt is easy to understand, just like in any other pneumonia. There is fluid, there is pus, there is debris in the alveoli, and that is what leads to shunt. Dead space ventilation is something which is quite interesting in these patients, because our understanding is that they do seem to have pulmonary intravascular coagulation. And on the basis of that, they do tend to get dead space ventilation as well. So this VQ mismatch is twofold in these patients, and by giving non-invasive ventilation, this is reduced, which results in reduction in the work of breathing, and that helps the patient. The important thing to remember here is that there is no change in the disease course. So the disease is still following its natural trajectory, and we are not interfering with the disease course per se. What we are trying to do is to improve in the symptoms of these patients. So next bit is the evidence. So what is the evidence of non-invasive ventilation when it comes to COVID-19? I think the most important thing to say here is that there is not enough data. We do not have enough data to give a consolidated single statement, an overarching statement that would cover this whole issue. At best, what somebody has described as COVID-19 is it's a chameleon. It keeps on changing its colors. Once we have an idea that we do have a hold of what is happening, it changes its colors, and our previous knowledge becomes almost redundant, and we then have to try and find out what else is happening out there. If we do not have a consolidated statement that could guide us, what happens then? What happens then is exactly what is happening in the COVID-19 situation. We then have to bank on our previous experience. The previous experience is then, it stems from the previous evidence that is published. In this case, SARS, MERS, and even things like Ebola virus. Experiences have been derived from these pandemics and then applied to COVID-19. And then comes the slippery slope, which is my experience. I gave tocilizumab to 3 patients, they improved. This is the slippery slope. This is the worst form of evidence. This is the lowest form of evidence. And this is anecdotal at best. And this is what is happening in COVID-19 as well. So we have to be very careful in deriving the evidence around anything, especially with regards to COVID-19. The first real evidence, the first statement that we find about non-invasive ventilation comes from WHO. In the interim guidelines that they published in January 2020, they included non-invasive ventilation as part of the recommendation in treatment and management of these patients. At the same time, almost simultaneously, the Chinese Thoracic Society also published in January 2020, Wang et al., they published the same, and they recommended non-invasive ventilation for their patients as well. This was then followed by Italian Thoracic Society, which was published by Vittel et al., April 2020, and they also had the same idea that non-invasive ventilation can be used in these patients, and they recommended use of it. All of them advocated non-invasive ventilation, but with a proviso. And this proviso is extremely important here. They all advocated special control measures. So the recommendation was based the fact that we can utilize this non-invasive ventilation, but provided we have special control measures in place. So what are those special control measures? We'll come to that later. Let's talk about, at the same time, well, this evidence in favor of non-invasive ventilation, what else was happening? In February 2020, French Intensive Care Society, Boudama et al., they published their work, and they practical considerations and management strategies for intensivists. In their paper, they excluded non-invasive ventilation. While excluding non-invasive ventilation, and they were quite conscious in their assertion that non-invasive ventilation could be excluded from their guidelines. This was then followed by March 2020, which was the big surviving sepsis campaign guidelines for COVID-19 management. And this was very interesting observation that they gave in their guidelines. What they said was they recommended that high flow nasal is preferable over non-invasive ventilation. So non-invasive ventilation was not outrightly rejected, but at the same time there was a question mark that high flow nasal, if available, is always more preferable as compared to non-invasive. So what it meant was practically that if high flow nasal is available, that should be preferred. And non-invasive should not be preferred, provided both are available. So this does confuse an issue. Is non-invasive not preferred at all, or it is just a comparative statement? So they left it open for interpretation. So what is the worry? Why are we worried about giving non-invasive ventilation to these patients? So the main thrust of the matter is risk to the healthcare workers. And the first paper that we come across was Hong Kong 2003. They wanted to look at the risk that is posed to the healthcare workers. In their work, they were not able to find any increased risk. However, another systematic review that was published a few years later by Tran et al., they said there is an increase in the risk of transmission to the healthcare workers. So we have twofold worries here. One is the ineffectiveness of non-invasive ventilation in these patients. The other one is the healthcare workers. Briefly, we'll talk about the ineffectiveness of non-invasive ventilation. There's only one proper paper about this, which is this Xiaobo Yang, which was published in Lancet, February 20. And what they said was that amongst the cohort of their patients, 56% of the patients required non-invasive ventilation, or 56% of the patients received non-invasive ventilation. Out of that 76% ended up having a tracheal intubation in place. So in order to interpret this, what it means is that out of 4, 3 patients were tracheally intubated. So can we interpret that in every 3 patients out of 4, non-invasive ventilation failed? We do not know for sure, but only 1 patient got better with non-invasive ventilation out of every 4 patients. The other worry is the aerosol generation. So the data that we have is that if we institute non-invasive ventilation, the aerosols that are generated are roughly in the range of 90 centimeters. When it comes to nebulization, this comes down to 85 centimeters from the patient. When it comes to mask ventilation, simple mask, face mask, this is roughly 35 centimeter plus minus from the patient. In the high flow nasal oxygen, which is the one that is favored by the surviving sepsis campaign guidelines, that is 10 centimeters. So that is significant. 90 centimeters versus 10 centimeters of aerosols. That is quite a significant number. So the clear winner here is high flow nasal oxygen. There's only one paper that has actually compared high flow nasal versus CPAP vis-a-vis risk to the healthcare workers. That was luckily published in April 2019. So this is before COVID times. So we cannot really say that this was affected by whatever is happening around us. And they found out that there was no difference between risk posed to the healthcare workers comparison of high flow nasal versus CPAP. So there was no difference in what they found. So what are we doing? So in our setup, we are giving non-invasive ventilation. The basic principles of intensive care medicine, critical care medicine apply. The patients who are requiring non-invasive ventilation are decided on the basis of the clinical grounds, and these are not any different from any other patient that we give non-invasive ventilation to. Just remember, as Professor Suneem has already spoken about, that some of these patients would be sitting with 70–80% SATs reasonably okay. So you have to decide clinically who you're going to institute non-invasive ventilation. Now let's talk about special control measures that everybody has been talking about, starting from WHO, Italian Thoracic Society, Chinese Thoracic Society. So what it means is that everybody needs to have personal protective equipment in place. So this is something which is extremely important. Everybody needs to have these equipment, wearing all these PPEs once they are approaching these patients. The other thing that we have done successfully in our setup is when we started off with COVID-19, we had 3 negative pressure rooms in our critical care setup. We successfully upgraded the facility to 32 negative pressure rooms. So if you want to institute non-invasive ventilation, although this is not recommended by any of the, we don't have any evidence to suggest that we must have a negative pressure room, but this is something that is going to help you. So we have the facility of negative pressure rooms in which we are providing patients with non-invasive ventilation. The other thing we have done quite successfully is positioning the patients while they are on non-invasive ventilation. So proning them while they are on non-invasive ventilation is no contraindication. So we have done that successfully. We prone them and provide them with non-invasive ventilation, and that does help them. When do we abandon it? Again, it's a very simple thing. It's a clinical decision. Starting non-invasive ventilation is a clinical decision, and once you stop giving non-invasive ventilation is a clinical decision. Either your patients have improved, or clinically now you've come to a stage and you think that non-invasive ventilation, they're unable to tolerate anymore, and now you need to intubate these patients. So it's again a clinical decision. Early intubation. We are not really sure where the early intubation, where we are at the moment. Again, the evidence is equivocal. You can argue both sides of the fence, but we are not convinced that early intubation is the way forward. We do non-invasive ventilation for these patients for quite some time. And the decision to intubate, as I said earlier, would be a clinical decision. So what is the conclusion? So the conclusion is that we have evidence in favor and against using non-invasive ventilation. There are recommendations in favor of non-invasive ventilation. There are recommendations that are not in favor of non-invasive ventilation. In our setup, we are using them. It does have its uses. This is not something that is at the back of the shelf. This is something which is very much at the forefront, and we will continue to use it. The thing to remember about is that we have to take special measures before we institute non-invasive ventilation. This is for the protection of the healthcare workers, and this is for the protection of the patients. Thank you very much.
Thank you, Dr. Hassan. That was very much in depth and a very much debated topic. लेकिन आपने इसको बड़ा simplify करके you explained it very well. Next, I would like to introduce our speaker, Dr. Asma Ashraf. She is an anesthesiologist here at Shaukat Khanum Memorial. She will be giving a talk on intubation practices in COVID-19, which, as you all know, are very high risk. And despite our last names, we are not related. Dr. Asma.
Thank you, Dr. Bilal. So I'm going to talk about the intubation practices in COVID-19, especially in relation to the critically ill patients. So as you all know that the SARS-CoV-2 virus is highly contagious and has globally challenged the healthcare workers and the medical systems throughout the world. The things I'm going to talk about is the risk of the aerosol generating procedures and how can we mitigate that risk in the healthcare worker using the institutional systems and also at the level of the hospital, and also developing the airway strategy at the team level or individual and department levels. So the information I have drawn from various sources, which I have mentioned here, but more importantly, it is the experience of the healthcare workers from throughout the world. Talking about the risk of the aerosol generating procedure, the data from all over the world, including China, Italy, and US, has shown that the risk of the healthcare workers who are doing the aerosol generating procedure is the greatest. So how does the virus transmit itself? So basically by direct contact or by droplet spread. And the droplet transmission is with the larger particles which stay in the air for a shorter period of time and they travel lesser distance. It is different from the airborne transmission, and the airborne transmission is with smaller diameter droplets which are called droplet nuclei, and they can remain in the air for a longer period of time and can travel the longer. So what is the risk? So basically our focus should be on the direct contact and the droplet transmission. The risk of the airborne transmission is less, but it increases significantly in certain conditions which are dependent on patient factors and the interventions which are done on these patients. The critically ill patients, they have a high viral load. So exposure to them super shudders, which with enhanced ability to transmit. The people who are more symptomatic, like coughing, sneezing, tachypneic, and the time spent with these patients will make you prone towards the airborne transmission. And similarly, there was a study done in 2012 which showed that the aerosol generating procedures like tracheal intubation, tracheostomy, and non-invasive ventilation, mask ventilation, they are the most high-risk procedure, followed by the other things like disconnection of the ventilatory circuits, tracheal extubation, cardiopulmonary resuscitation before tracheal intubation, bronchoscopy, tracheal suction without a closed inline system. That are all risk factors for a potential airborne transmission. So how can we reduce that risk depends upon how well we are prepared. So we should be prepared well in advance of actual airway management taking place. So that when in February, when different communities were battling in the heat of the coronavirus, some communities had time. So our first patient was registered in Pakistan was in February. At that time in Shaukat Khanum, we were kind of doing preparation to deal with the COVID intubation and the COVID management in terms of the critically ill, moderate to severe critically ill patients. So we had preparations at institutional levels and team levels, and what I'm just going to tell you what actually we did. So this is the the model which has been proposed by the National Institute for Occupational Safety and Health from America, and that can be easily, incorporated into a hospital infection control plan. So I'm going to talk about the last three, but actually it starts with the elimination of the virus. So you have to reduce the entry of the virus into the hospital. So the patient who were presenting with the respiratory symptoms were triaged by screening in the COVID camp or the triage system, which was placed outside the hospital. So these patients were not directly entering into the system. Those patients who required the management for these respiratory symptoms and subsequent airway management was required, they were placed in the negative pressure rooms in ICU and COVID dedicated wards. So here comes the engineering controls which become important, and the healthcare workers should know that what hospital design they have got, what setup is there to reduce the exposure. At that time, we also anticipated that this critical care might be expanded to the areas which are actually not equipped, for example, the positive pressure operating rooms. So what we did was that we increased the air changes per hour to 20 plus in our operating rooms to reduce the viral loading inside the theaters. It doesn't stop here. The administrative controls are extremely important, and we make sure that we have a trained staff and equipment and resources in terms of hand sanitizers is available, trained staff in the COVID intubation, and also checklists were prepared and training was done for the donning and doffing steps. And decontamination of surfaces, equipment, careful waste disposal, these are all important. And if you look at this picture, you see that PPE is only part of the system. It is not substitute. But because it works well, there is no substitute for full appropriate PPE for aerosol generating procedures. We made sure that we do the training and the simulation drills in the PPE use, especially the doffing practices and hand hygiene. A buddy system was introduced and the checklist was placed in the ICU and the COVID wards. The important thing here is to train the staff about the correct PPE use. Airborne precaution is the minimal appropriate, which include the gloves, face shield, goggles, N95 mask and gown. They should be simple to remove. They should cover the whole body, disposable, and should be disposed of immediately after the doffing. I will really like to emphasize the importance of the double gloving here, because it not only gives extra protection to the airway manager, but also minimizes the spread by fomite contamination of equipment and surrounding. So just after the airway manipulation, the outer glove should be removed. Now, finally, I'm going to talk about the airway strategy which we planned, and it was based obviously from different societies' recommendation. Tracheal intubation, anyways, in a critically ill patient is a high-risk procedure with a lot of physiological challenges. These two studies by Nolan and Higgs showed that around 10% of these patients who are critically ill develop severe hypoxemia. They do 2% of them experience cardiac arrest, and also the first pass success rate of tracheal intubation in these patients is less than 80%, with actually 20% requiring more than 2 attempts. And these figures actually could be more, significant in patients who present with COVID for the COVID intubations. These were the driving forces behind the principles of the airway management, which we later on did. So Tim Cook and his colleagues actually, developed a consensus guidelines which were published in May this year. And they show that the airway management actually should be safe. Accuracy is critical, not using unreliable, unfamiliar techniques, and it should be swift without any rush and delay. And these recommendations actually focus on the choice of the equipment, selection of the staff, and the technique which is used. Who is the most appropriate person to manage the airway? Most of the recommendations suggest that it should be the most experienced anesthetist or the most experienced airway manager. In our hospital, we decided that the consultants should be doing, consultant anesthetist would be doing the intubations in the planned elective cases. The reason was that it will ensure high probability of success at the first attempt, and we know that the multiple attempts are likely to increase the risk to the staff during these procedures. Another thing which we made sure was that we involved the smallest number of the staff. Only the staff which has to do the intubation should be there. So minimally you need about 3 people inside the room, with one intubating, the other managing the cricoid and equipment, and the third one gives the drugs and also monitors the patient's vitals. The fourth one is the runner, which stands outside the room and watches and calls for help if needed. After the role allocation, you have to make sure that when you are still outside the room, you make sure that your drugs and equipment is needed. So this is a typical equipment you would need for intubation in a COVID patient, which includes all the airway drugs, intubation, and ETTs and LMAs, yankers, and a disposable C-circuit, or it should be decontaminated, video laryngoscope, tube clamp, and emergency front of neck X kit. So not all the things should go inside the room. We decided that we made a list of the drugs and equipment which will be actually inside, which will go inside the room, so that the number of the equipment which needs to be disposed of or decontaminated is reduced. Then what type of the equipment should be used? That is another thing. There's a lot of debate about the single-use equipment versus reusable. Obviously, the single use is better, but it may not be of the same quality. It may not be available. Supplies may run short, and in that case, you have to reusable equipment has to be used, and make sure that this is appropriately decontaminated at the end of the procedure, so that we minimize the risk not only to the frontline staff, but also that staff which is involved in the transport and decontamination of equipment. The technique would vary depending upon the experience of the airway manager and also the equipment available. The main thing is that these intubations should be planned rather than crash intubations, so that we allow time to the staff for the safe donning of the PPE. Do not use the techniques that you are not trained in, rather use the one you know the best and which are known to work for most of the patients, especially in the difficult airway patients. Checklist helps a lot. It serves as a cognitive aid, and they should be there in different rooms where the COVID intubations are expected. This is one from the Royal College. We had one similar to that in our hospital. Just to recap the whole thing, the things which have to be done outside the room is that don the PPE properly, allocate the personnel, communicate with the staff, prepare equipment and drugs, and plan for the difficulty while you are outside the room, because when you are inside the room, the communication with the staff will be difficult with all the PPEs donned. The Difficult Airway Society guidelines have been actually simplified in order to accommodate the COVID situation. The vortex approach can easily applied for the intubations of the critically ill patients. Once you go inside the room, make sure that your patient is optimized. They are usually desaturating, or they may have less saturation. Wrap them up, start pre-oxygenating. Make sure there is an HME filter between the face mask and endotracheal tube and the circuit. Also make sure that the sample line is attached distal to the filter. And once you start pre-oxygenating with a well-fitting mask, this VE approach tends to work better, as shown by the experience of the Difficult Airway Society members, and also this barrier protection by the plastic works well. I'm going to talk a little bit about the barrier protection later on, but as such, the rapid sequence approach would be the approach, obviously, which will be adopted with or without the cracoid course, which will be applied by a trained assistant and has to be removed if there is a difficulty encountered. Then the things which will become important is that make sure that what is the hemodynamic status of the patient, and choose your drugs accordingly. Make sure you have a vasopressor boluses and infusions available. And this third thing which is important in the actual intubation process is make sure that the patient doesn't cough. And for that you need a full neuromuscular blockade with a good dose of the muscle relaxant. It could be rocuronium. We don't have rocuronium in our hospital, so we use Sux in 1.5 milligram per kg dose. Back mask ventilation has to be avoided to avoid potential aerosolization, but CPAP can be given once the patient is asleep. And to assist the ventilation, we will minimize the oxygen flow. If we have to use the bag mask ventilation with minimal flows, with minimal pressures, and a supraglottic airway device can be used. The laryngoscopy is done with video laryngoscope, and these are usually done and enable the operators to stay at a distance from the airway. If it is not available, the standard Macintosh blade and bougie with a preloaded stillet can be used. Inflate the curve, start the mechanical ventilation, check the capnogram, try to avoid the stethoscope, and then resheath the laryngoscope and seal all the equipment in a double Ziploc plastic bag. And once you have done it, avoid unnecessary circuit disconnections. If you have to disconnect, use the clamp, doff very slowly and carefully, do the hand hygiene, and then you can do your. There are a lot of barrier techniques. The main thing to learn about them is that they may aid in reducing the viral load, but they do not lessen the importance of effective PPE. There is no substantial data available, and some people think that actually it slows down the intubation time. These are the aerosol boxes available. A lot of them actually do require disinfection, and there could be difficult manipulation in difficult airways. These plastic bags are more kind of useful. This is another adaptation, and also I will like to ensure that we have clear and closed loop communication. This is just a few things about the cardiac arrest, and I will just wrap up my talk here that by just emphasizing the fact that wear PPEs according to the Resuscitation Council guidelines, and SAD may be used before the tracheal intubation, and early intubation is recommended. Thanks a lot.
Okay, thank you very much, Dr. Asma. That was very much in depth, and I think she did a great job in explaining how we are practicing safe intubation in COVID-19 patients. Next up is Dr. Rehan Akram. He will be talking about thrombosis and steroids in COVID-19. Dr. Rehan Akram is our critical care and emergency medicine consultant and director of our ICU. And after him, we are moving, due to some minor issues with IT and related systems, we are moving some of the talks. So after Dr. Rehan Akram will request Dr. Amber Sabeen, and the order will follow. Dr. Iqbal Hussain from PKY will join us a little bit later within this time. And I'll make this announcement again later. So for now, Dr. Rehan Akram, he will be presenting thrombosis and steroids in COVID-19.
Assalamu alaikum. Bismillahirrahmanirrahim. Thank you very much for everyone joining us, and thank you for the presenters to help us in arranging sort of an all over Pakistan COVID-19 ICU webinar. So thrombosis has become extremely important as the time is going by. We'll quickly go through thrombosis and steroids over the next 10 minutes. So first we'll go through a bit of a history and then a bit of pathogenesis, then the recent papers, and then what we are doing in our approach at shock assignment. So just in the last few weeks, there have been about 9 publications just on thrombosis in COVID-19, and I've read through about 5 publications from 2002 to 16 with regards to COVID-1 and MERS with related to thrombosis, which was present in those gene-related viruses or the viruses related to COVID-19 as well. So in SARS-CoV-1 as well as in MERS, actually there were quite a lot of incidents of thrombi and pulmonary embolisms and multi-organ clots along with polyangiitis and strokes. VTE in one of the studies was thought to be up to 30%. Fibrin thrombi was found in pulmonary vasculature, which was from Lancet. Pulmonary, bronchial, and small vessel clots of all sorts were seen, and multiple organs were involved in these clots, not just the pulmonary system. But because the scale of spread of COVID-1 and MERS was not as extensive as this COVID-19, this probably didn't came to as much limelight as COVID-19 did, and much of the hypoxia and further deterioration in patients' cardiopulmonary physiology is probably related to these multiple clots, subsegmental, segmental, or VTEs, and in other organs as well. There were fetal complications in COVID-1. Now we haven't so far gone far enough and haven't seen much published with regards to fetal complications in COVID-19, but there were oligohydramnias, intrauterine growth retardation, small fetal size, and which was attributed to subchorionic fibrin deposition. And of course, the damage was related to the extent of the deposition. Anticardiolipin antibodies were positive. Lupus anticoagulant was positive, and again in now different studies showed that actually these were also positive in the recent COVID-19 publications. The assumed pathogenesis, which at the moment is being postulated, is that the type 2 pneumocyte, which is called the AS2 receptor, gets infected, then there is further cell lysis leading to endothelial damage, and then due to the intrinsic pathway, there is the cascade activation, fibrin deposition, along with pulmonary microcirculation clot, and what we call pulmonary intravascular coagulopathy starts, and then vasculature gets clogged up as the time goes by. Hypoxia ensues, pulmonary artery pressures rises, leading to increased right atrial pressures, decrease in pulmonary venous return to the left side, decrease in left ventricular volume, and hence the decrease in sound pressure. So this is one assumed mechanism through which it works, and possibly there are many more as well, especially related to inflammation of the vessel itself, and then thrombosis due to inflamed vessel in that site. And we have seen that in coronary thrombosis, cerebral thrombosis, arterial thrombosis in the limbs as well from India. With regards to the recent publications, this was probably the first one from China in March 2020 that showed that treating with heparin, the 28-day mortality was less than the people who were not treating with heparin. The criticism on the study was that the prophylactic heparin or prophylactic flexane is not the sort of normal routine in intensive cares in China. But nevertheless, there was a difference in when you were treating with heparin and not heparin. When we go further, this was the Netherlands paper, Incidence of Thrombotic Complications in Critically Ill People with COVID-19. Some very important paper in the first of its kind in the recent days. In this study, despite the prophylaxis, there was 31% incidence of thrombotic complications in intensive care. And these thrombotic complications were not just limited to the lungs. They included arterial thrombotic events, cerebral events, and there was also multiple cerebral infarcts, along with there were some hemorrhagic complications within those infarcts were seen as well. Pulmonary embolism was seen in 27% of these COVID-19 patients, but they didn't compare it to a sort of a non-COVID ARDS patients and how many of those would have got. The next paper that came up was this one, which is accepted paper but hasn't published yet, and it's really a good read and is a really an in-depth review. And it's a French study that shows that the PE in their patients was seen in about 17 patients. CRRT circuit plotting, despite the standard use of anticoagulation methods, was about 96%. And we have also experienced that in intensive care at Khanum, that circuit plottages of CRRT are more than our normal ICU population. ECMO circuit plotting was seen in 8% of this French population. 95% had elevated D dimers in fibrinogen. No patient developed a true DIC. 87% tested positive for lupus anticoagulant, and this is a very similar result to the COVID-1 and MERS. When they matched these ARDS patients of COVID-19 and non-COVID-19, in the COVID ARDS, they had 17% of patients at PE versus 2.1% in a normal ARDS, non-COVID ARDS patients, which is such a massive high complication rate from VTE. This is not a normal DIC, what we used to see before. The PT, APTTs are usually normal. PT is usually a bit more abnormal than APTT. And this is again consistent with since 2002 in COVID-1 as well as MERS. And here you are seeing a lot of publication, a lot of numbers, and that is why this is becoming a bit more apparent. Now, the platelet count is mostly raised. Only about 5% of patients will have a reduction in platelet. In one of the recent studies just published last week, the platelet drop in platelet does not correlate with a high mortality. But whereas a D dimer, the D dimers are massively high and they keep on rising in the non-survivors. And if the DNR is downtrending, the people are usually getting better. Fibrinogen are raised compared to being low in a classic DIC. Now, the peripheral blood films in these patients are unremarkable. There are no eaten up cells, there is no pictures like MAHA, there is no schistocyte. So, in summary again, this is actually not a classic DIC. You would have normal coagulation patterns that you would see. You would have raised platelets, you would have raised D dimers, and which would keep on rising, which is not a good trend. So, in view of this, our approach is that when a patient arrives in ER, we take a D dimer and we give them a milligram per kilogram of Plexin, which is the therapeutic dose if we give it BD. By the time the next 12 hours are due, the D dimer is back. If the D dimer is raised, we start them on to therapeutic anticoagulation. They go on to therapeutic anticoagulation if they need a hospital admission. And the hospital admission meaning thereby if they have an oxygen requirement, they will be admitted. If they do not have an oxygen requirement, they will be educated about it and discharged. If they do have an oxygen requirement, they will go on to therapeutic anticoagulation in ICU as well as on the COVID ward in our hospital. And during the admission, we do an active watchfulness for the further signs of DVT or worsening. Now, further to this is as we are seeing more spread in our population, the more and more questions are coming. And a recent case being that a 70-year-old uncle or aunt in the house who is diabetic, obese at home, who is now COVID positive, but is not hypoxic. And the question arises from a family member that should we do a D dimer? And if we do a D dimer, should we actually start them on to some sort of prophylaxis for clots? And I've discussed this with multiple colleagues and along with our hemo people. And we decided that with the ones that are at higher risk with those features of diabetes, obese, sedentary lifestyle, one approach that has been suggested is rivaroxaban 10 milligram daily, which is sort of a dose that we give to our patients who are, let's say, a post-knee replacement and are going home. And in that way, we haven't really exposed them to massive danger, and we have potentially covered that bit as well. But doing a D dimer is especially important so that we are aware that where we are progressing. So if I sum up, anticoagulation is a must. Prophylactic dose is not enough. We need to go higher. 1 milligram per kg BD is what we are doing here. If your institute is doing 1.5 milligram per kg, that I guess is okay as well. But if you can do factor 10A levels, do factor 10A levels. If patient goes into renal failure, please switch to heparin to a full therapeutic dose, 70 to 90 of APT. Now, this is a really good slide. And as you can say, stage 1, stage 2, and stage 3. And this is important to emphasize that when to start steroids, or should we give it in all patients even when they have the slightest amount of cough, or should we start them at a later stage? No one knows the true answer. We'll go through evidence what we have so far. So sort of one of the first papers with the initial COVID one, and again the similar problems were there then as well. This is from 2004. And in this paper, what they gave early corticosteroids, and what they saw was that there was increase in viral titers of the qPCR of the viral RNA, but there was no deterioration of the patient. And when they gave the steroids at a later stage, there was no increase in titers, but there was improvement. So could it be that they were measuring the wrong endpoint? Possibly, because the endpoint of a clinical study should be a clinical endpoint rather than a viral titer. And that increase in viral titer does not lead to a worse outcome. So this paper is mostly presented as a evidence against steroids, whereas if you closely look at it, actually that's not the case. So patients treated with early steroids were less likely to deteriorate clinically. That was one of the endpoints, along with the increase in viral titers. But those increased in viral titers did not lead to clinical deterioration. So the second one is from 2006. This is again from SARS-1 from China. And this paper showed there was overall lower mortality. There were shorter hospital stays and intensive care stays. It was not associated with increasing secondary infections. And this was a really important outcome from it, that when we think that if we are giving standard empirical antibiotics and if we start them onto steroids, would secondary opportunistic infections, would they increase? Now, the steroid dose that is being given in most of these studies is actually not very high, and what we are doing in our unit is not high as well. And I will go through the dose that what we are doing at the very end. This is from 2016, for the MERS experience with the ARDS patients. And among the patients with the non-severe disease, steroid use were generally non-beneficial. And this is a bit different from the first two, but there was no harm to the patients. And among the patients with the more severe disease, steroid correlated with an improved survival. And here, I think the crux of matter was that probably the moderate to severe disease, or at least the severe disease, should get steroids. This is just from about 2 weeks ago, again from China. It's a single standard from Wuhan, the first area that got the bulk of the patients. The steroid therapy correlated with more rapid oxygenation improvements and radiographic improvement as well. The patients treated with methylpred were weaned off oxygen earlier, a median of 8 days versus 14 days. And this, I think, was a major improvement, 8 versus 14, and you are able to wean them off early, discharge early from ICU, and potentially reduce the time on vent or NIV or the other oxygen providing devices. This one is again from China, from JAMA, and the take home was that the methylpred may be beneficial to the people who have severe disease. Which is again consistent with all the previous diseases. So essentially, if we sum up, there is no prospective RCTs. There is no strong evidence that we should give them from the very start. But certainly, when you have got a patient who has got severe disease or moderate disease, steroids should be considered. The low dose that we are giving is about 0.5 to 1 milligram per kilogram of prednisolone per day. And prednisolone is just being used as a reference. If you do 1 milligram per kg of pred a day, you can convert it to hydrocortisone or any steroid that you have got and give that intravenously to the patient. This is a really good sort of a time frame that how we could prevent these people from getting worse. And early intervention is the key. And as Dr. Shamim from AKU in the first talk was talking about awake proning, that is the first point here, that if you do an early intervention, possibly we are able to avoid intubation with the help of proning, with the help of BiPAP, with the help of high flow nasal, whatever your institute is used to, judicious fluid administrations, and stop the nephrotoxins, because we are seeing our patients going into AKI, but usually there is clear precipitant before they go into an AKI. Either is a drop in BP or the cytokine storm or a nephrotoxic drugs like M4 or colistin being started. Heparin administration to prevent thrombosis. Now, this is massively important, and this has come absolutely to the very forefront in the last few weeks. we suggest therapeutic anticoagulation in all of the patients who are admitted. The go-to should be Clexane, as it is easy to administer. But if the patients are developing thrombi while on Clexane and we cannot monitor factor Xa levels, then probably best to switch to good old heparin and monitor them properly as they should be. Low dose steroids to prevent hyperinflammation. Yes, we are doing that, and we are using 0.5 to 1 milligram per kg of blood. Avoid intubation and multi-organ failure as much as you can, and as suggested by Dr. Shameen as well, that people are tolerating hypoxia and tolerating a state where patient is not much in distress but is hypoxic, like the classical acronym being happy hypoxic at 88 or 85, sitting up or prone, and you can maintain them for a few hours to a few days and may be able to avoid intubation, of course in intensive care, and closely monitoring them, that if they do need intubation, then you are there then and there to intubate them and help them through this a week or two of intubation. Hopefully when the virus recovers, and they will recover with it. Delayed salvage is intubation if it is required, absolutely. In Pakistan, especially at STM, we are seeing very delayed presentations. We are near the motorway, and when they come off the motorway from distant cities, this is the first hospital that they come across, and then land here with a SACs of 40 or 50, and we have got no choice with a semi-conscious person apart from to tube them. We have used CRRT, and we have seen increasing clotting despite using standard pre-filter heparin, and we have used systemic anticoagulation as per this previous slide of heparin anticoagulation, and then only we have seen that the filters have been clotted. We haven't used TPA, but there are studies of the TPA. Along with the TPA, I forgot to mention one point. There is one study with the aspirin that shows promise, but it's a preliminary result and it's not published, and this is something to look out for. Why is that? That in the clotting cascade, the clots are forming at all times, and the plasmin pathway is working all the time to dissolve a clot in normal human being. With this further mechanisms with gene amplifications and the endothelial damage and the tissue damage leading to the cascade, we really don't know how exactly the clot propagation is happening. But certainly platelet aggregation in the post-mortem studies, these are platelet-rich thrombi. So this study is would be one to look out for, that if aspirin would be helpful. Certainly in the patients that we have who are on aspirin, they are not stopping their aspirin. The patient who should be on aspirin, the 75 milligram or 100 milligram prophylactic dose, they should be on aspirin. So this is something to look out for probably in the next week or two as next studies come out, that aspirin or similar anti-inflammatories NSAIDs that may modulate the platelet function would benefit from it. Now, the last point here, which is the tocilizumab, one of my friends is going to talk about it. And so I wouldn't talk about that much. And low dose steroid we already talked about. Worst long-term functional outcome we don't know as yet. Certainly with severe ARDS, we have seen very prolonged recovery times, and pulmonary rehab was markedly difficult. Alhamdulillah, we have had only one mortality of non-cancer COVID patient. We have discharged about 4 of them, and all of them were in good shape and discharged. Thank you very much, and I hope you have learned a few points from it. The Q&A session will be at the end. Feel free to drop your questions, and thank you very much again for all the participants that joined. Thank you.
Thank you, Dr. Rehan. So, and thank you for doing this. I find this kind of talk very difficult, where you have to tackle 2 or 3 different subjects within one talk. And I'm sure there will be many questions at the end regarding your topic. So Since we had to change the order of the talk to some extent, so next up is Dr. Salma Abbas. She is our ID consultant at Shaukat Khan Memorial Hospital. She will be talking about therapies for COVID-19, what works. And after Dr. Salma, we should have Dr. Ambir Sabeen ready with her talk. Thank you so much.
Assalamu everyone. I'm Salma Abbas. I'm an infectious diseases consultant at Shaukat Khan Hospital. Thank you for the opportunity to speak on a very important topic, which is coronavirus disease 2019 or COVID-19 treatment and what works and what does not work. So I'm going to start with a disclaimer, which is that to date, there are no approved anti-infectives for the treatment of COVID-19. There is no consensus on which drugs to use. The therapies that are currently being prescribed are either investigational drugs or used in an off-label capacity. We do have some existing evidence for the medications or therapies that are currently used. Initially, we mostly had observational studies, case series, and case reports. And more recently, RCTs or randomized controlled trials have started to emerge. If you look at clinicaltrials.gov, about 508 trials have been registered to explore treatment options for COVID-19. That brings us to the next important question, which is what treatments are currently being used for COVID-19? So literally the kitchen sink has been thrown at these patients, starting from hydroxychloroquine to chloroquine, to natural remedies, to ivermectin, to plasma therapy, to tocilizumab, remdesivir, Litra, montelukast, Arbidol, favipiravir, natural remedies again, or standard of care, or nothing at all. This is a very vast topic, and I could actually spend hours if I try to review every treatment that has been used so far. But in the interest of time, I'm going to stick with the treatment options that are available in Pakistan, have been used in Pakistan, or have been used internationally with success and should be considered for treatment in Pakistan. So I'm going to start with the most popular drug that has been used thus far, which is chloroquine or hydroxychloroquine with or without azithromycin. So what was the mode of action, or what was the rationale for using chloroquine or hydroxychloroquine with or without azithromycin? So, excuse me, I lost my screen. Okay, is this being shown? Okay, sorry for the interruption. So I will be reviewing treatment options that are available in Pakistan, or those that have shown benefit internationally and must be considered for use in Pakistan. Starting with chloroquine and hydroxychloroquine with or without azithromycin. So what is the mode of action or rationale for using these therapies? So chloroquine and hydroxychloroquine were used in vitro studies, and they raised the pH of endosomes and prevented viral entry into cells. What are the key toxicities? There's QT prolongation, which can be seen immediately with a few doses or even one dose that's high enough, and retinal toxicity, but that's something that you see with very high cumulative doses. Between chloroquine and hydroxychloroquine is thought to be safer. What is the existing evidence for chloroquine or hydroxychloroquine with or without azithromycin? So initially we had in vitro studies, then we had observational studies. We recently saw some RCTs emerged that compared high with low doses of chloroquine or hydroxychloroquine. They saw that higher doses were associated with death, and that trial was terminated prematurely because of this reason. Then recently, 1 or 2 weeks ago, a large cohort study on cancer patients came out, and they basically compared hydroxychloroquine with hydroxychloroquine and azithromycin or chloroquine or no treatment at all. So hydroxychloroquine and azithromycin were associated with higher odds of a 30-day mortality among cancer patients when compared to either drug used alone or no drug at all. Then recently, over the last 1 week, 2 observational studies came out, and in general, studies have described up to a 40% incidence of QTc prolongation among patients. One of the recent studies did not show any benefit or harm with hydroxychloroquine, and a recent study that has been retracted as of today, that was published in the Lancet, created much hue and cry about use of hydroxychloroquine, and it basically showed evidence of harm, but no evidence of benefit. There were inconsistencies in the data that was published, and there was lack of transparency. Therefore, the study has been retracted. We had enrolled for a WHO trial, which had hydroxychloroquine as one of the treatment arms. It had been briefly on hold, but upon review of this data, WHO has decided to go ahead with this arm, and we will be going ahead with that trial. So, what is the verdict for hydroxychloroquine or chloroquine with or without azithromycin? So, we did initially include this in our SKM institutional protocol, but we have removed it because there hasn't been overwhelming evidence to support its use. We will be using it in the setting of a well-designed trial, and that's how it should be used. On to another drug, lopinavir ritonavir. So this is an anti-cancer treatment. It's a viral protease inhibitor. What are the key toxicities? It causes QTc prolongation, hepatotoxicity, and GI side effects. Existing evidence for lopinavir ritonavir. So this was the first trial that came out on COVID-19 treatments. It was a randomized control trial with 199 patients enrolled, allocated 1:1 to lopinavir ritonavir versus supportive treatment. There was no difference between the two groups in terms of mortality or viral decay. So it did not really show a benefit. Recently, a multi-center prospective open-label randomized phase 2 trial was published, and that compared interferon beta-1b with lopinavir ritonavir as well as ribavirin. That was administered to 86 patients, and compared that to lopinavir ritonavir, which was administered to 41 patients, and the total duration of therapy for both these groups was 14 days. Now, it's important to note that only 17 of these patients, that's 13%, were requiring supplemental oxygen, and 6, which is 5%, required ICU admission. So most of these patients either had mild symptoms or very low oxygen requirements. So the results of this trial cannot be generalized to very sick patients or those who are hypoxemic. So the combination group revealed that the median time for the nasopharyngeal swabs to become negative was significantly shorter in the treatment group than the control group. Again, when you talk about patients with mild symptoms, 80% have mild symptoms, and most of them recover without any intervention. So it would be interesting to see how patients who are very sick would do with this treatment. It's hard to say at this point if it was treatment benefit or the natural course of the disease that they recovered. So verdict on this is to use in the setting of a well-designed clinical trial. Moving on to tocilizumab. So what is the mode of action? It's an IL-6 receptor inhibitor, and why should we use it? Because IL-6 causes cytokine release syndrome in COVID-19 patients. And what is cytokine release syndrome? Basically, lab parameters that we use to define it are CRP of greater than 70, ferritin of greater than 700, and D-dimer of greater than 1 microgram. What are the key toxicities? Immunosuppression, hypersensitivity reactions, hepatotoxicity, cytopenias, hepatitis B and TB, reactivation, intestinal perforation, and what are the contraindications? So it's important to note that this drug is not without side effects or contraindications. That's important to note these. So systemic infections, ANC of less than 2,000, ALT greater than 5 times the upper limit of normal, and allergies. And what is the existing evidence?
So initially, very small case series were published, and more recently, we had a larger case series that was published. This was an Italian study, 100 patients, out of which 88 were males, 12 were females, median age of 62 years, with confirmed ARDS were included in this study, and 57 patients were admitted to the general ward versus 43 in the ICU, and this is because they did not have beds in the ICU. So this is why the 57 patients were on the general ward. So what they saw with tocilizumab, and they administered 800 milligram times 1 and repeated the dose in 12 hours if lab parameters did not improve. So they saw improvement of the ward patients. They saw improvement in 37, which is 65%, who came off non-invasive ventilation. 7 or 12% remained on NIV by the time they were looking at this data. 13 or 23% worsened. Out of these, 10 died, 3 were admitted to the ICU. Of those, 43 were admitted in the ICU, 32 or 74% improved, 17 of them were taken off the ventilator, 1 person remained stable, and 10 or 24% died. So look at the high percentages of people in both groups, general ward on NIV, and those who were intubated in the ICU improved. So 65% and 74%. So that's a very high number. And this is a very promising therapy. And based on this and our institutional experience, what's our verdict on this? Observational studies support the use of tocilizumab. Do consider it in patients with evidence of cytokine release syndrome without any contraindications. And as I said, we are using this at our center with good results, and it's part of our institutional treatment protocol. Now moving on to convalescent plasma. So what is the mode of action? What is the rationale for use? The rationale for use is that convalescent plasma is rich in neutralizing antibodies, or that is the thought to give it to these patients. What are the key toxicities, allergic reactions, transfusion-related reactions? And what is evidence? So again, initially small case series were published, and with mixed results. They were not adjusted for co-treatments, baseline characteristics, disease severity, or the timing of plasma delivery. And RCT came out. This was done in China, and they had initially hoped to enroll 200 patients, but they were only able to enroll 103 because of the containment of the epidemic in China. And what they did was they compared convalescent plasma with standard of care versus standard of care alone. The 28-day mortality was 15.7% in the treatment group with convalescent and standard of care when compared to standard of care alone. But the p-value was not significant. Again, the rate of discharge at 28 days was 51% for those receiving convalescent plasma with standard of care versus 36% for those receiving standard of care alone. The p-value was not significant. However, this was an underpowered trial. They did not achieve their sample size because of the containment of the epidemic in China. So the numerically higher figures for improvement and lower mortality are important, and should be used as a basis for better designed future studies with further further elucidate the role of convalescent plasma in the treatment of COVID-19. We need further studies with larger sample sizes. Again, this therapy needs to be explored further. We need to use this in the setting of well-designed clinical trials. The challenge, particularly in Pakistan, has been trying to quantify the titer of antibodies that are present in convalescent plasma. So internationally, the protocols recommend that it needs to be higher than 1:640. There is a trial, to my knowledge, at least one trial that is going on in Pakistan, but we haven't been able to quantify the titer of antibodies. And we have not yet used convalescent plasma at our center. Moving on to remdesivir, it's been marked with an asterisk because this is not yet available in Pakistan. What is the mode of action for or rationale for use for remdesivir? It's an RNA-dependent RNA polymerase inhibitor. The key toxicities are GI side effects and hepatotoxicity. This is the summary of evidence. Initially, an observational study with about 60 patients came out that supported its use, but there was no treatment, no control group for comparison. Then recently, RCTs have been published to look at the role of remdesivir for treating COVID-19. The first one enrolled 1,059 patients assigned 1:1 to remdesivir versus standard of care. There was early recovery among those requiring supplemental oxygen, but not those among those requiring NIV mechanical ventilation or those who were on ECMO. Again, there was no mortality benefit seen in those with severe illness. So this was a little disappointing for someone like me. We were hoping that we would find that magic drug to treat COVID-19, but so far we haven't seen very promising results with remdesivir. It's encouraging and needs to be explored further. Who knows, maybe as a result of further studies, we may find that this is the cure for COVID-19. But as of right now, there's not very strong evidence. Then again, another study compared 5 days of treatment versus 10 days of remdesivir. 397 patients were included in this study, randomized 1:1, and the outcomes in the two groups were comparable. Verdict: it may be beneficial if used for hypoxic patients before they progress to severe respiratory distress, because that was one of the things that was seen in RCT. So maybe we don't have to wait for patients to become critically ill. If we administer this among patients who are hypoxic but not yet severely ill, this may be beneficial for them. This needs to be investigated further and used in well-designed trials. On to prophylaxis. So there has been one RCT that was published to explore prophylaxis for COVID-19. A total of 821 asymptomatic adults with moderate or high-risk exposure to a known case of COVID-19 were included in the study, and they were either given hydroxychloroquine or placebo within 4 days of exposure. They saw that there was a higher incidence of side effects in the hydroxychloroquine arm, but there was no difference in incidence. What is the verdict? Is that there is currently no role for prophylaxis. It's not recommended. What is the bottom line? Bottom line is that current evidence is hypothesis generating but inconclusive. There are some studies with stronger evidence for some medications versus some other, for example, tocilizumab, remdesivir. But we do need further studies. These drugs may be considered for use in patients with moderate or severe disease where no contraindications exist, and it's best to limit the use of these drugs in clinical trials. And no talk on treating COVID-19 is complete without mention of prevention. So please stick to good cough etiquette, perform hand hygiene vigilantly, and maintain social distancing. Thank you.
Thank you, Dr. Salma. That was a very extensive talk about things which work in COVID, and definitely hydroxychloroquine does not work. So next up we have Dr. Fakar Raza from SIUT. किसी तारुफ के मोहताज नहीं है critical care community के अंदर. He's very well known, and he is running a very successful program at SIUT. Inshallah, he will be on next, and he will be presenting ventilation strategies in COVID-19. So Dr. Fakar, you will be on in just a few seconds.
Can you hear me? आवाज आ रही है? जी आपको आवाज आ रही है? डॉक्टर बिलाल आपको आवाज आ रही है? ठीक है. Bismillahirrahmanirrahim. My name is Dr. Fakir Raza. I work in SIUT. This is the largest kidney disease center, and we have been doing transplants for many years now. 6,000 transplants has been done, and we are doing around 1,000 dialysis every day. So you can safely say that this is one of the biggest transplant and dialysis centers of at least this region, if not over the world. आपको माइक से आ रही है, अब आ रही है सही आवाज? हाँ, मैंने तो हैंड फ्री लगाया हुआ इसलिए आई डोंट नो। ठीक है, बिस्मिल्लाह। The thing is that we are doing basically all of these services free of cost for everyone, without irrespective of any caste, creed, or the economic status. I have nothing to disclose today. I would be just talking briefly about what we had been doing in last couple of months as far as COVID is concerned. We just converted one of our newly built ICUs. Actually, we started this ICU with the COVID patients. So this is right from the start that this dedicated ICU has been started with this. So the place, I don't know whether you can see or not. This we have actually built for specifically for these COVID patients, because we just wanted to see everything in our room as well, besides the bedside, because the movement in and out is a bit difficult because of these PPEs. So we have admitted 116 patients, out of which 80 were males and 36 were females, and the average is around 50. Bulk of them were with renal failure, yani कि dialysis dependent, or one or two were acute kidney injury as well. We intubated 58 patients, total died 42, and overall mortality was 35%. No proning 43, self proning 28, awake plus ventilator proning 3, on vent alone was 23, and we don't have the data for 19 patients. They died 16 out of 43 without proning, self proning 2 out of 28, and then self plus vent, that is we tried a few with very severe respiratory failure, so all of them died, and on ventilator 13 died, and we don't have the data for the rest of the 8 deaths. The standard of treatment that we are using, definitely standard ICU care plus anticoagulation. In the therapeutic doses, methylprednisolone, BID, hydroxychloroquine we initially used, and after a few patients, maybe 30, 40 patients, we stopped it. Anticoagulation we started very early. After first two or three mortalities, we started anticoagulation right away. Tocilizumab have been given and IVIG. Usually we start with ceftriaxone and levofloxacin, and definitely we do have 6 beds with dialysis and CRRT, whatever is needed for the patient. So coming back to the topic which has been given to me, the bottom line is what is written in the first line, is that after intubation we need to spend good 1 to 2 hours with the patient. We sedate, paralyze, and we know the minimum oxygen requirement with low PEEP. Then we do the lung recruitment maneuver in our patients, and then we tend to know the optimal PEEP, and then we again check what is the minimum oxygen requirement on that optimal PEEP. So this is right after intubation, you have to stand at the bedside, and we are doing all definitely all maneuvers, ultrasounds, X-ray, and all these lines, etc., before we do the proning. Besides that, on the ventilator, this is what we actually do. There are certain things very, very interesting that we found in, especially in the COVID patients, that we were not seeing in last maybe 15, 20 years. That is the what we do, lung compliance versus PEEP. This is first thing that we have to see, that if you give extraordinary high PEEP, you decrease the lung compliance and you compromise on the heart as well as on the saturations and definitely the compliance. So easier way to is to decrease the PEEP by 1 and see if the plateau pressures decrease by 1 or more. If the plateau pressures decrease, for example, you got the PEEP of 14, and and the plateaus are like 28, And if you decrease the PEEP to 13 and the plateaus goes to like 25, that means that you are giving more than required PEEP. And that is how you can actually decrease the driving pressures as well, just by decreasing the PEEP and seeing whether the plateaus are going 1 by 1 or 1 by 3 or 1 by 4, whatever. So you can actually decrease the driving pressure, and we should target driving pressures less than or equal to 14. But usually we're not able to do that. We have to compromise on that. And I actually didn't see much, any bad results with using the higher driving pressures as well, because my objective is to actually extubate early rather than keeping the patient on low volume, high PEEP, high respiratory rate, sedation and paralysis, and and keep on lingering on with the ventilation. I tend to use higher tidal volumes with lower PEEP, and at least it is allowed in my patients who are the COVID patients. So you can ventilate with the physiological approach. You won't need to paralyze. I just coming out of the ICU. 3 of the patients were on sedation and paralysis. I stopped the paralysis on all 3 patients. I just increased the volumes to like 600 plus, could decrease the rate easily, could oxygenate in a better way after recruitment. I didn't have to give a lot of PEEP, like 5 to 8 of PEEP I am giving, and definitely I could stop the paralysis. So I did stop the paralysis. Minimum sedation is required. My intent is to open up the lung and get the patient out of the vent as soon as possible. So what else is needed? I don't know whether this clock is running like 23 minutes. How much time I have? So we have to address constipation. That compromises my ventilation. Definitely, I have to address constipation. I have to, after seeing the X-ray, if the stomach is full of air, you have to suck that air out, and that may help actually. You have to see, if you have to compromise on carbon dioxide, you may actually opt for low carbohydrate diet, increasing the fat and other things. That may be effective and may not be effective, but this is a strategy besides what the ventilator is doing. Watch for surgical emphysema. You are using high pressures. There are chances of the lung trauma. Use ultrasound, more than what we do in the lungs, heart, abdomen, everywhere. We are just usually using it for the line insertion, but now it's just like a stethoscope in the ICU. So we have to learn it, and we have to use it more frequently. Besides that, if the patient is hypoxic, it could be because of the low cardiac output. So you need to improve that. You have to hydrate the patient actually if you need to. Renal failure ke andar, we are afraid of giving a lot of fluids, and we are also afraid of taking out a lot of fluids. But when the patient is hypoxic and you have got the arterial line and the pico lines and all these things, you can actually predict what you want to do and what you should do. So invasive monitoring is something that will help in a hypoxic patient. It's not just the blood pressure, it's also the cardiac output and the hydration status and all that. I would recommend in our scenario where we are compromised with the staffing, we should use least number of invasive lines as much as possible. This is what is contradictory to what I just said, that is the invasive monitoring. But invasive monitoring maybe first 24 hours, 48 hours, and then your patient is going to be extubated. So remove the lines as soon as possible at least. This is something I wanted to share. How can you actually avoid intubation? Those with single organ failure, renal failure is something we have to take care of. This is something the patients are coming with. So the patients don't have any kidney function, they are dialysis dependent. Besides renal failure, if the patient just have respiratory failure, then you can think of using high flow nasal cannula, non-rebreathing mask, self-proning. I'm now using self-proning with NIV. and that is actually very effective. You can see a couple of papers on that as well, and you just saw when I was presenting the data of self-proning that 2 out of 28 were intubated, or maybe 3, I don't know, but all those who were intubated, they couldn't survive actually. So the thing is that the self-proning does work. We have avoided a lot of admissions in ICU. We just kept them in our HDU, which is, in another building. We have to shift the patient from there. So we avoided a lot of admissions in the ICU just by doing the self-proning. So that is something I wanted to share as well. Control of agitation. I have been using this dexmedetomidine very frequently in my ICU. इतनी ज़्यादा TT की आवाज़ें होती हैं, the patients are really very in a lot of trouble. So मुझे use करनी पड़ती है. I'm fond of haloperidol. Many people are not. I have not seen a lot of complications, so I have a bit of confidence still on haloperidol. And then, if you don't want to avoid intubation, you shift the patient out of the ICU. So this is something you can actually try. So I have been shifting the patients on like 4 or 5 liters of oxygen, and patient got better in the HDU as well, because I need space in the ICU. I don't know how much time is left, but this is something that I actually presented last month in another webinar as well. The COVID-19 ventilation clinical practice guidelines. This is ESICM. So इनकी guidelines हैं, ये बहुत आसानी से available हैं. You treat hypoxia. You don't want and you don't want to give a lot of oxygen as well. High flow nasal cannula is better than NIV whenever it is available. Initially we had a lot of high flow nasal cannulas, then उसकी supply का problem आया, हमने NIV use किया, उससे भी अच्छे results आए, लेकिन शायद HFNC is better than NIV in our setting. And then ARDS settings, yes, the conventional setting, लेकिन मैंने आपको बताया कि we are using higher settings in our patients, COVID patients, and they are giving us good results actually. Plateau and PEEP, I already talked about it, that and you already know that the target plateau is less than 30. Target, what you call that, driving pressure, the plateau minus PEEP should be like 14 or less. ये strategy हमें रखनी चाहिए. Recruitment maneuvers right from the start, and then you may actually do it every shift. You have to recruit. You may have to recruit, and especially you should avoid paralysis and heavy sedations. So if you could recruit easily, you can actually do good. Fluids, हम लोग patients को दे नहीं पाते because we are having renal failure patients. So I'm anyway using conservative strategies, because otherwise I have to do daily dialysis. I actually am doing daily dialysis. I have been using CRRT for even 48 hours, more than 48 hours in some difficult patients. So this is my majburi to use conservative fluid strategy. Proning, I have already talked about. I think what we are using, we are actually following this European society guidelines, whatever we are doing. So yes, but we don't need this 12 and 14. We actually have to go far more than 16 hours. Sometimes say 24 and more hours. So, you just have to see what your patient needs in that time. Neuromuscular blocking agents, I'm not very fond of it. I'm trying to avoid it. कुछ और जो ड्यूटी पे डॉक्टर्स आते हैं अपनी शिफ्टों में, तो they tend to use it because in that way the patients don't move. But I'm just trying to build up a culture of using NMBs as little as possible. This may be because my background is not anesthesia. My background is medicine and pulmonology, so maybe that is the reason. ECMO, I'm trying to build this ECMO service in our hospital. It's still not available, but this is something that is actually needed, that may save life. I've been working in Qatar, and we have been having the severe respiratory failure center there, and we have saved a lot of lives with the patients with ARDS, massive PEs, post CPR and all that. So we ECMO and we ECMO all are good, and we should be aiming in our centers. But you know, basics are basics, and we should always try to stick to our basics. कहाँ गया बिलाल भाई? So this ends my presentation for today. Is it 15 मिनट में हो गया? पता नहीं. Thank you.
Thank you, Dr. Fakhr. That was very much in depth, और आपकी आवाज़ भी बहुत अच्छी आई है. Slides were amazing, and the talk was amazing. अब आपके लिए कुछ questions हैं, Dr. Fakhr. So at the end हो सकता है आपको थोड़ी सी तकलीफ देनी पड़े, specifically event related हैं और आपकी talk के related हैं जो audience ने भेजे हैं. So we'll go over those at the end. अभी ये कि Dr. Amber is going to present. She is having some technical issues, so hoga ye ke she will be presenting her slides, and we'll have her on the phone from here. So inshallah, just give us a few seconds. Dr. Amber will be next. So like I said, Dr. Amber is next. She will be sharing her slides. Dr. Amber, please, you can start.
Assalamualaikum. I'm Dr. Amber Sabeen Ahmed, consultant critical care at Khan University. Today my topic is fluid management in COVID-19. Fluid and critical care literature dates back to around 18th century at the time of another pandemic of our age, cholera. At that time, the German scientists reported good resuscitation goals achieved with fluid, and a similar study was repeated by English scientists also. Then in 1834, in the Lancet, later has reported a letter to editor that the fluid hemodynamic status of the patient improved after fluid resuscitation. In 1864, then the fluid was again came into literature for hemorrhagic shock, and then subsequent trials established it as a form of therapy for hemorrhagic shock. Till 1864 to 2001, the fluid in septic shock literature was only based on physiological rationale, but there weren't any evidence-based literature. Then in 2001, Rivers have conducted the early goal-directed therapy, which established fluid as a form of treatment for septic shock management. This therapy, though, was questioned in 2014 and 15 by RI's process and promise analysis, which considered the use of fluid as not that beneficial. Fluid in critical care is one of the most commonest intervention, and it is the most debatable and the most controversial intervention. SST guidelines have recommended 30 cc per kg fluid volume for initial resuscitation. but it has got its own benefits and disadvantages as well. Though fluid therapy could lead to early resolution of shock and lactate clearance, but at the same time, it can lead to tissue edema, worsening hypoxia, and organ dysfunction, especially of lungs and kidneys. The fluid constituent itself can be harmful. Similarly, it can also give rise to intra-abdominal hypertension. So the optimum fluid therapy needed remains a question of interest in critical care literature. Like with inadequate fluid therapy, there's danger of tissue hypoxia, cardiopulmonary event, and if not given properly in the resuscitation phase. But if given too much, it can lead to volume overload, organ failure, and increased ventilator days, even leading to hemodialysis. So in the septic shock literature, after the surviving sepsis campaign, the subsequent study showed a significant decrease in mortality with fluid from 47 to 31%. But there are studies then which also showed no results with fluid therapy, as I've mentioned earlier, the RISE, Process and Promise trial. And a study done in Africa in pediatric population actually showed harm with fluid therapy, and it didn't found it beneficial. The critical care literature was still debating about the fluid therapy when Classic and Rift trial was done in 2019, didn't show any fluid benefit. But at the same time, we have a global pandemic of COVID-19. Till to date, around 66,98,615 cases are reported in around 213 countries and across all the globe. The disease course in COVID-19 consists of fever, cough, dyspnea, but at day 9 and day 10, which you can see in my slide, it leads to sepsis, and by day 10 to 12, people can also develop ARDS. So this is the time when the patient starts becoming critical. The fluid management in COVID-19 is still an area untouched by literature. All the data we have got is the data on ARDS, and the recommendations are extrapolated from the ARDS data. The landmark track trial of ARDS, which showed a conservative versus liberal fluid strategy, showed duration of mechanical showed low fluid, decreased duration of mechanical ventilation, but there was no mortality difference. The RCTs done after that show risk of death similar in the liberal and conservative group, although the increased ventilator-free days and ICU length of stay was seen with conservative fluid therapy. So the fluid management in COVID-19 is still not clear. In the initial period when it was discovered in January, February, March, the literature was suggesting negative fluid balance. But when the subsequent studies showed higher than expected renal failure in patients of COVID-19 ARDS, and the renal replacement requirement was higher than before. Patients are present at different stages of their illness. They might be having fever and hypovolemia, or at times GI symptoms are also a prominent symptom along with respiratory symptoms, making up patients hypovolemic. So it's an overall strategy that the conservative fluid treatment would be the way to move forward for COVID ARDS patients. The question arises when these patients went into shock. That there are two types of ARDS pathophysiology in COVID-19. Similarly, as vent management, the fluid management for the both type of treatment as reported in literature earlier on, that same literature of ARDS, not of COVID-19 specifically, by European Respiratory Society, showed two types of ARDS, and the uninflamed ARDS responded well to fluid therapy, whereas the reactive ARDS with hypercoagulability showed bad response with fluid therapy. So the question remains about the patients who have septic shock and ARDS in COVID-19 patients. The septic shock with ARDS was found to be a cause of mortality in greater than 40% cases of death. So it is one of the major causes and needs to be addressed properly. Similarly, refractory heart failure with cardiogenic shock, probably direct myocardial damage, stress cardiomyopathy, right heart failure due to prolonged ARDS also contribute to decreased myocardial activity. So the question is not of the patients who are having ARDS where the conservative fluid treatment is the goal of therapy and it's decided everywhere in the literature. The problem comes when the patient with COVID ARDS goes into septic shock. There are four crucial questions in this regard. When to start giving IV fluid therapy? Should we give or not? And then the other question would be, if we have given IV fluid therapy, should we stop giving therapy and when? And then once we have stopped IV fluid therapy, should we start removing IV fluid? And if we are removing IV fluid, when to stop this fluid removal? So these are the four crucial questions which become even more important in the setting of ARDS. So there are no direct evidence, as I've already described, that there are no direct evidence of patients with COVID-19 and shock to date. All the data which were used by the societies are the data acquired from the patient in ARDS. Right now, we have surviving sepsis campaign guidelines. The WHO have already given their own guidelines, and the UK anesthesia and intensive care guidelines are also there. So what does surviving sepsis campaign say? They are recommending dynamic parameters for volume assessment like skin temperature, capillary fill time, serum lactate measurement, and deciding about fluid therapy in a septic shock patient accordingly. As everyone is saying, they are going for conservative fluid therapy, and in fluid we are favoring crystalloids over colloids. And then even in crystalloids, the balanced crystalloids are recommended, and the recommendation are against starch, gelatin, dextran, and in this guidelines, even against albumin. Although the evidence for all these recommendations is very weak and low quality. Then we have WHO recommendation. It's also saying the same thing about conservative fluid management. But in case of septic shock, WHO is recommending 250 to 500 ml of crystalloid fluid as a rapid bolus in the first 30 minutes. And then they are saying to reassess for signs of fluid overload after each bolus dose. If there is no response to fluid loading or if signs of volume overload appears, then recommending to stop giving any more fluid. They are also suggesting to continuously checking dynamic indices of volume responsiveness, like passive leg raising, fluid challenges associated with stroke volume measurement, variation in systolic pressure, pulse pressure, IVC size, or stroke volume in changes to intrathoracic pressure during mechanical ventilation. WHO is strongly recommending against any other fluid like a starch or dextran. Then the third guideline we have got so far is from UK Joint Anesthetic and Intensive Care Guidelines. They are also favoring conservative fluid therapy, but in case of hypotension or circulatory shock, they are recommending appropriate fluid or pressure. All these therapy, I didn't go into pressure therapy as it would make the topic too complicated, but they are all recommending earlier pressure use along with fluid rather than delaying it. They are also, everyone is recommending balanced electrolyte solution and more conservative administration later on to carefully balance against the risk of inducing acute renal impairment. They are saying to be too cautious in fluid management as running patients too dry can also be harmful to the patient. So you have to maintain an exact balance. For general patient, they are advising for optimal fluid status, and as a part of management protocol, the IV fluid status of the patient should be assessed daily. The choice of fluid would always be guided by the biochemistry and the volume status of the patient. Once the patient has enough volume, they are recommending diuretics. So based on all these guidelines, the International Fluid Academy has made a plan for fluid management. They are recommending that the fluid balance should be assessed on these patients daily, along with electrolyte measurements. And dynamic measures of fluid responsiveness, especially cardiac echo or ultrasound, should be performed daily on these patients if possible. In case of resuscitation, they are recommending a safer regime of, rather than going for 30 ml per kg, previous recommendation of septic shock. Apart from then, they are recommending 4 ml per kg of balanced crystalloid and then giving it as a bolus in 10 to 15 minutes. Fluid responsiveness would be then assessed before and after each boluses with functional dynamics, example pulse pressure variation or passive leg raise testing or an expiratory occlusion test. They are recommending for early initiation of vasopressor and assess for the presence of fluid overload if there is 10% increase in the body volume. For maintenance therapy, they are recommending using balanced solution only if rarely needed. If the patient is able to eat or drink and the fluid status is balanced, taking care of all intake and output, they are not recommending IV fluid therapy. If IV fluid therapy as a maintenance dose is really necessary, they are recommending for 25 to 30 ml per kg per day of water and balancing it with the electrolytes along with others. So the recommendation now for fluid in COVID-19, till we have a proper RCT or a proper study done to assess the status, is moving targets along with moving goals. Like your all targets should be goal directed. Like for your target one in the initial phase will be early adequate goal directed therapy. But then the target two, just as the patient is hemodynamically stable, then it would be late conservative fluid management. And then in the target three would be the fluid removal strategy. So the resuscitation point would be always goal directed, like increasing the stress volume of circulation, restricting the initial resuscitation strategy, and proactive approach to achieve negative fluid balance. This would also bring on the question of fluid stewardship. This is recommended by International Fluid Academy. Just like antibiotic stewardship, there are rules for fluid stewardship. Like they are always saying the 4 crucial questions which I already discussed earlier, that when to start fluid, when to stop fluid, when to start removing fluid, and when to stop removing fluid. Like if I go back to my slide, the when to start should be when the pulse pressure variation is high, the positive passive leg raise signs show fluid responsiveness, and there is increased lactate. When to stop fluid, when the pulse pressure variation is gone, there is no response to passive leg raising, and the lactate has normalized. When to start removing your fluid, when your intra-abdominal pressures go up, and low abdominal pulse pressure would be known as when MAP minus IAP is low. And then there is positive cumulative balance. When to stop this fluid removal is when you have low SCVO2 and low abdominal pulse pressure. So this is the way forward for fluid therapy, which would be guided for each patient differently. And the indication would be the resuscitation. Maintenance, as I've already mentioned, it would be better to use oral fluid if possible, and replacement and nutrition therapy. And they are saying to use fluid therapy as a drug, which as any medication needs its dosing, duration, and then knowing when you have to stop the fluid therapy. So the 4th stage of resuscitation, which was an initiative taken by British Society of Anesthesia around 3 years back, of resuscitation, optimization, and stabilization, and then de-evacuation should be applied. The 4th hit when you have to consider fluid therapy is the initial insert when a patient with COVID-19 develops septic shock. Then you have to look for the ischemia, reperfusion injury, and then you have to look at the fluid accumulation and global increased permeability syndrome as well. And the 4th hit would be And then the 4th hit would be hypoperfusion during resuscitation phase. If during patient again started developing shock, then you have to know when to start this deresuscitation. Hopefully there will be further studies and things will be more clearer, because when septic shock develops in ARDS, it's one of the most challenging conditions. Thank you.
Thank you, Dr. Amber. And despite technical difficulties, I think you delivered an amazing talk. This is one topic which gets ignored, how much fluid to give and when to give. So thank you very much. I'm sure there will be some questions for you later. I don't see them right now, but if you are available, please stay tuned. Next, we are going to have Dr. Aftab Akhtar from Shifa with us. He's pulmonary medicine and critical care and running the ICU at Shifa in Islamabad. And we will need a few seconds to join him. And after Dr. Aftab, inshallah, we will have Dr. Iqbal Hussain, who also worked at Shifa in the past, but currently is director of ICU at PKLI. So stay tuned, give us a few seconds, and Dr. Aftab will be on next, inshallah. Okay, Assalamualaikum, Dr. Aftab, आप हमारे साथ हैं, so please Bismillah कीजिए.
Yeah, Bismillahirrahmanirrahim. Assalamualaikum everybody. So the topic today is post-extubation care of COVID-19 patients and beyond. And this is, I think, a very, very important topic. And what I'm going to share, I don't have much data on it, but what I'm going to share you is what we have learned as an institution and as a person in the last 2 months. Hello? Any आवाज?
जी, Dr. Aftab, please continue.
यानी आवाज तो आ रही है यार?
हाँ जी, आपकी आवाज इधर आ रही है। आपका मेरा ख्याल है जो आपने मीटिंग में लॉगिन हुए हैं किसी और डिवाइस के थ्रू उसको या साइलेंट कर दें या
Okay. So first I'll talk a few slides on the extubation. And with the extubation, we know that there has been recent advances in the ICU practice, but the extubation remains a significant challenge, as we know that extubation failure carries a significant weight of morbidity and mortality. There are several winning strategies which are present in the literature, but I guess the most important thing is the organized approach and the consistency in practice. Next slide, please. Is the voice clear? There's a lot of echo.
हाँ जी, आप अपने कंप्यूटर का माइक ऑफ करके देखिए। वो ऐसे ठंडी भी जानते हो कि वो बात करें। ऐसे ठंडी भी जानते हो बात करें। जी, वो आपने एज एन अटेंडी भी ज्वाइन किया हुआ है, उस अकाउंट को बेशक बंद कर दीजिए। I think much better.
This is better, huh?
Yeah, please go ahead.
Yeah, so next slide करें Bilal?
जी.
Next slide नहीं आ रही है. Next slide इसमें नहीं आ रही है Bilal.
जी, यहाँ पे तो okay. Can you see it now?
Yes, this is the same slide, which is despite many recent advances on.
So there's a delay for 20 seconds, so keep an eye out. Can you see it now?
No, I mean the slide is the same. Should I do it once? क्या ये स्टक सी होगी Bilal? ये स्टक?
जी, एक सेकंड दीजिए।
जी जी।
हाँ, मैं आपको एक सेकंड
Yeah, Assalamu alaikum. Sorry, there was some technical error. So we'll continue with this data which I'm going to share with you, which is personally what we have learned in the last 2 months. And as far as the post-extubation care is concerned, it is basically threefold. You have to think about one is the patient care. Number two is you have to take care of the medical personnel. And third is the family. Next, please. Next slide. Okay. So, as far as this slide is the medical personnel, right? So, as you can see, your first mode duty is the patient care. So, in the patient care, you can see there are two major things that you are dealing with. You are dealing with the oxidation and the ventilation. Obviously, you are looking at the APGs and the PO2 and the PCO2. And then depending upon the patient demand, I mean, sometimes you need high flow nasal cannula oxygen, and sometimes you will be needing ventilatory support with the BiPAP and the CPAP. Then at the same time, you will be dealing with, you will be asking the patient to encourage the patient with intensive spirometry and a cappella and obviously the CPT, which has some downsides as far as the COVID-19 patient and post-extubation is concerned. Because once the patient is extubated, now the patient is talking and is coughing. So there's a lot of things going on because you have exposed the nurses and you have exposed the RTs. Then once you take care of this oxygenation and ventilation, because sometimes it is, as all our doctors know, that once you extubate the patient, sometimes they will not be extubated 101, fulfilling the whole criteria, and sometimes you just have to take the tube out. And then you will be needing a lot of non-invasive ventilation, which is called a weaning in progress. Then, after taking care of the oxygenation and the ventilation, then obviously there are many other things that you have to consider when the patient is still in the ICU or post-extubation. The most important thing, obviously, like any other ICU, secondary infections. So in the secondary infections, you are concerned about the bed sores because sometimes they have a prolonged ventilation support and they are in ARDS, so you cannot really change the posture. So bed sores are not uncommon in these patients, so we have to keep a close eye on it. Then you have catheter-related bloodstream infections. You make sure because there's so much things going on with the data and so many patients. Make sure the lines about the line sepsis. Then obviously whatever the guideline that you are using, we are using steroids up to 14 days. So make sure that once the patient and the oxygenation and everything is better, then there's a very thin line that you start cutting down on the steroids. And most of the patients are on antibiotics, so you have to really think about the de-escalation. And these 3-4 things are very, very important, like in any other ICU patient. Because once they get infected or once they get side effects of steroids, all your hard work in the last 2 or 3 weeks is gone. Then another thing I just want to tell you is that if you can see the slide, that when you look at the slide, this oxygenation, ventilation, here the respiratory therapist, I mean, this what we have, I mean, we know and everybody know, but especially in this epidemic, it is highlighting the importance of respiratory therapists, the RTs. I mean, how crucial they are to the ICU and to us, because when we are rounding, obviously your first question will be post-extubation, that how much is the BiPAP setting, and how much the patient is off BiPAP, how much the oxygen requirement is when you are dealing with the high flow, obviously the flow and the oxidation. So they have a very, very pivotal role. And obviously nurses, who is the mainstay of any ICU, they play a very important role. Then once you are oxygenation, ventilation, and the second infection, then obviously most of the patients are getting paralytics, they are getting sedated. So obviously the critical illness, neuropathy, the risk is very high. And then obviously you are dealing with a lot of physiotherapists. And here, the role of physiotherapists is extremely, extremely important. Some ICUs, they ask the physiotherapists not to come to the COVID unit. Some ICUs do. And then finally, obviously, once the patient is in the ICU, there is a chance of CRS to secondary is utmost important. I cannot underscore this one. And then the physician role obviously is there, but all of you who are listening, who are the leaders in the ICU, who are the juniors who are listening, who will be the leaders in the ICU in the next coming years, I mean, this is what we have learned, that this post-ICU, ICU care, this is nothing but the teamwork. And in all these, what I have told you, respiratory therapists and the nurses, the administration has such a pivotal role, and that underscores that how much the physicians, which we often see a gap, that the physicians should be constantly in touch with the administration. Because as you can see, I mean, everything, the baseline support will be supported by the administration. And that's what we have learned, that this is our team of respiratory therapists. They are celebrating their respiratory week. This is our fellows, and we are very blessed that we have fellows and very like PGs. They are fellows, means that they are fully trained, either a pulmonologist or a medical specialist. And even if at night at 2 a.m. there's a drop in during output, they will go and do the ultrasound, and then the fluid management will be done. So it just tells you that how important is infrastructure and the fellowship. And then once we have taken care of this patients, now you come to the medical personal care, because both sides to take care of the person who is surrounding the patient, because they will be taking care of the patient for a long time, hopefully. So, you know, once you are thinking about the medical personal care, the period of is up in the air. Some data says that they are infected 14 days, and sometimes the PCR positive means that they are picking up. I hope you're on the next slide.
Yes, we are on medical personnel care. Yes.
So infectivity period, so somebody will say that they are infected 14 days, and somebody will say the PCR is positive. You have to do the quantitative test to make sure that it is not the active RNA or inactive RNA. But whatever the thing is, the period of infectivity, when the patient is extubated, I mean, you should take it as the highest possible, because they're coughing and talking, and then there's a loss of AGPs going on in the form of stabilization if needed, and sometimes CPTs, and obviously I told you about the NIV. Then, I mean, you know about the nurses. I mean, you have to, because they're sitting in the room all the time. Then you have to take care of your artists, which are coming into the room every 2 hours, maybe more. And then the doctors who have to come twice or whenever needed inside. So they all must be protected. Next slide, please. So what can we do? What we have learned, that's what we can do at least for the nurses and for the house staff and for the RTs. First we can do is we can give them gratitude, because I think they are the bravest of the bravest. And all the doctors who have been fighting with this COVID, I mean, you all know that when you get the PPE and you went inside the room with the vent or the non-invasive ventilation, and still after 2 months, I mean, I too get a tachycardia when I go inside and talk to the patient and examine the patient. But these are the persons who are sitting with them 8 to 12 hour shifts. So, I mean, it is your duty that you must ensure that there should be strict PPE informants and enforcement, and there should be supplies, which is only possible if you have a very good liaison with your administration. And then it is not always possible that if you can give the hard yearly allowance, because they are all working very, very hard. Next slide, please. And last, what everybody knows, that don't underestimate the power of this housekeeping. I mean, they are one of the frontline taking care of not taking care of the patient, but at least, I mean, they are cleaning up. Know that if there is effective housekeeping, it's really cut down on infection. and they are at very high risk, and they are doing it with a very, very minimal age. So, I mean, all these things, the last thing is what we have learned in this COVID is the family counseling. And in fact, one of our rheumatologists when we were reviewing all therapeutic data, the end statement was that he said that basically the treatment of COVID-19 is nothing but counseling. And we have learned that it's counseling, counseling, and counseling. So the third part in taking care of the patients in the post-COVID era and obviously during the intubation is the family counseling. Because you remember, as far as we are concerned, we are in a private setting, so there's a lot of emotional trauma which is universal. Then there's a financial trauma which you get in the private hospital. Then there's a physical trauma that you are sitting, whoever the attending is, for 4-6 hours shift outside the hospital. So the counseling is very, very crucial element of the treatment. And whatever you are treating the patient, but if the counseling is not sufficient, I think the treatment is not really optimized. And all these things, I mean, this is what we have learned, and we are still learning. This is not the end of once you extubate the patient. That's just the beginning of the end. But I just started in the beginning. But it just when you have extubated the patient, then you have started the cleaning of the patient, and then there's fighting with infection. At the same time, they're dealing with the families. Then you send home the patient. Then you send home patient. Then it is not over yet, because whoever is taking care of the patient, you know there's a lot of shit going on. So it is the home healthcare services that needs to be given to the patient in the form of sometimes bed sores and make sure the D-dimer is okay, then to cut off their anticoagulants and infections and water supply. So, I mean, this is what we have learned so far from our experience, that teamwork is everything. And this just highlights the importance of respiratory therapists, our nurses. Basically, there's a dire need for high ICU medical personnel, like the fellows. There should be fellowship slots should be increased, and the family counseling, and obviously a very, very close liaison with the administration. So post-ICU care, I can share you one of our 2 patients. This is day 54 of one of our patients, but it is not day 54 today. I made it almost a week ago, so it's almost day 59 now. And he's still on oxygen. We are sending him home, and we have bed sores, and we are still dealing with it. And this is one of the jobs, but he was on the bench for 19 days. Then there's another patient who was day 36 now. He has gone home, but he was still requiring oxygen, and he was really a critical illness, and he was needing a lot of physiotherapy. So, I mean, at night I can say that nobody has seen COVID before. There is no data. You can talk about R and WhatsApp about the data, but there is no data because nobody saw it coming. And so this post-ICU care, we all will be learning together. Now we know what the complications will be, now the patient knows, and the journey will go on and on. And I think this will be one of the most talked subjects in the coming years. So I congratulate this sort of team, Dr. Bilal and Dr. Vakar, that they have picked up this very, very important topic. And with this, take on the job. Thank you very much. This is the last time.
Yes, thank you. Yes, definitely. Thank you, Dr. Aftab. Majority of us really focus on the initial phases of the illness, and most of us are worried about, providing enough oxygen if they're in shock, trying to get them out of shock. But then many of us don't really plan. What will be the post-extubation, what the post-extubation phase will look like. So thank you, Dr. Aftab. I think this was an amazing job. What you did summarizing everything regarding to post-extubation care. Next, we will be inviting Dr. Iqbal Hussain from PKLI. He's the director of ICU at PKLI, and he will be joining us within a few seconds. And the topic, he has been dealt a tricky topic, which is bedside ultrasonography in COVID-19 patients. So give us a few seconds and Dr. Iqbal will be online. ठीक है. So, thank you. So just let me know whenever everyone is ready. I'll ring the bell 3 minutes before the end of your talk, just to give you a reminder. वो bell करेगी. वो क्या चाहिए आपको? यहाँ पे चाहिए. हाँ, इस तरह से बजाएंगे. अच्छा. ठीक है. What do you need? No, I think I'm fine. See, let's محمد بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي واحلل عقدة من لساني يفقهوا قولي. Thank you very much for giving me opportunity to come to Shaukat Khanam. I've been here before, so I won't take much of your time. I'll go directly to the topic that I have, and it is my privilege that I got this opportunity to talk to my colleagues about my experience that we have been having with ultrasound on our COVID patients. So before I jump into how we do ultrasound in our patients, I would just briefly go on the recent study just came out a few days back at Critical Care, and it has said basically that the study by Megan at Critical Care that there is a significant number of 60% of the patients, they have thrombotic events, and there is a very high incidence of pulmonary embolism. Therefore, doing venous Doppler studies make perfect sense in these COVID patients. And we have already discussed many times at different forums that why regular dose or extended dose or the antithrombotic dose of enoxaparin or in cases of renal failure, IV heparin is important. And the same part of the study has mentioned that these patients also have a high risk of hemorrhage as well, which they reported about 21%. So I just wanted to bring this into attention that if we use a high dose of enoxaparin that we have used or we are using the anticoagulation dose, then we have to be careful in terms of the complications that may arise. Okay, one more study that I'll mention from the China, published at New England Journal of Medicine, and this can highlight basically why it is important to do the bedside echo. And as you can see that there is a high risk of myocardial injuries. We have already discussed that there are reported cases of myocarditis. There are increased risk of pulmonary embolism with RV strain and the shock
which is very, very common. There is another study which would be coming out from France. They have reported 60% of the cases who have shock as well. And I'll tell you what we have faced in our group of population who got intubated. So I'll be sharing in my next slide as well. Before I go into the discussion that why it is important to do the venous Doppler studies and echo, I would just briefly mention our experience, and then I'll come back to this slide again at the end. We are doing venous Doppler studies on all patients. So far, we took care of about 28 patients. All of them, they have done the venous Doppler studies. About half of them I have done, so I do not invite my radiology colleagues to do venous Doppler. And literally it takes 3 minutes for me to do this, including the color as well. So it's very easy to do. I can assure you if you do 3 cases, you'll be able to do it. It's not that difficult. It's not a rocket science. You can go to Google and do the YouTube, and you can see it yourself. And most of us, we do femoral lines anyway, so we are familiar with the anatomy. And then in terms of echo, everyone who's on the ventilator would get echo. That is the case in our hospital. We had about 7 ventilated cases, and we did echo on 6 of them. We are going to do the 7th month today, hopefully, and I'll share my findings at the end when I'll come back to this slide. Lung ultrasound, we have done almost on all cases. Total echoes, we have done about 12, and all 12 of them we have done lung ultrasound, and all of the patients, they showed B lines. So I see no reasons to do lung ultrasound unless chest X-ray showed some pleural effusion or some other need that you think that you need to tap something. Then, of course, you would need lung ultrasound to save the CT scan. And then, like I said, all patients who are on the ventilator would get venous Doppler for sure and would get echocardiogram. And from my experience, what I've noticed in terms of people who are familiar with echo is that if you're doing the echo, it is difficult to do on these ventilated patients. One is the lungs are hyperinflated because they are requiring higher tidal volume, as you all know, number one. Number two, 4-chamber is really difficult, and many of them would require proning as well. So it's not that easy to do it. So what I've noticed that if you do parasternal long and short axis, especially long axis, you can calculate EPSS. That can give you some calculation in terms of the functionality and ejection fraction of the heart. And if you want to conduct the studies, then it can be very useful that you have some objective number to document in the chart that you can follow up. So that is my experience, that EPSS was easy to calculate. Number two, what is very easy to do was subcostal view, because you are already looking at the IBC, and then the IBC, I'm going to talk in a little bit more detail at the end, is very important because many of them, they do require paralytics, and it becomes useful when you have a paralyzed patient to check the IVC responsiveness. And many of us, we already do that, especially when we do the PLR, passive leg raise. So that is what I wanted to share. And at the end, I'll tell you what type of echo findings I've noticed in my experience. I've done on 12 patients, at least many of them I've done multiple. So I can share my experience if you have any questions. Now coming back to how to do echo, because many of us, we are novice to this. I've been doing it for quite a while, so it's easy for me to say that it's easy, but that's not the case. How you do it, the most important thing is there are many videos available on the YouTube. The easiest thing that you can do is you put the probe on the second intercostal space with the probe pointer at the 11 o'clock position, and you do the parasternal long axis. Long axis will tell you about the pericardial effusion, and it will tell you the opening and the closing of the mitral valve. So what you're looking at, the anterior wall motion, which we look at the EPSS. So when you calculate, you're looking for the number 0.6 or less. So E point systolic excursion, we call that EPSS stands for. So that's the parasternal long axis. As you can see, that this is parasternal long axis, this is apical and subcostal. Apical may not be easy to do it, so I'll skip here. So parasternal long axis, like I said, pointer position at 11 o'clock at parasternal long axis. In short, you have on 1 o'clock. Subcostal, easy to do. You're already doing the IDC checkup anyway. Okay, now I'll skip that a little bit. Let's talk about parasternal long axis. Now you can see the orientation that this is the diagram which shows the location of the heart in standing position. Let's make it this person supine. And as you can see, that you'll see the right ventricle, left ventricle, anterior posterior valve, aorta, and the left atrium. Because the time is short, I'm really cruising fast through this presentation. So if you have any question, I would love to do some more in the future. Okay, so we have already discussed that. Parasternal long axis, I already discussed that. Now let's look at these video. Okay, now I can assure you that you can do this. If you do 5 of them, all you need is a persistence how to do it. Okay, so here's what we look at. Let me see if I can play it again. Okay, this is right ventricular outflow tract. This is left ventricle, and this is left atrium, and this is aorta. I don't know why it's freezing up. Let me see. I have no idea why it got frozen up. Let's see if it, okay. Right ventricular outflow tract, left ventricle, this is left atrium, this is left, this is aortic root, okay? The most important thing that you may need to look at is the pericardial fluid, okay? And this is descending aorta. You just need to get your eyes trained on that, not very difficult. It may looks like French right now or Chinese, but as you practice or do it at the bedside, it'll be easy to do that. Okay, now let's talk about the short axis. What we are looking at short axis, many patients who are intubated, may be sometimes difficult to get the short axis. You're looking at the probe position pointing towards 1 o'clock, and then what you are interested is basically the septal bowing. Okay, so if you see the septum is moving inward, then you might be dealing with the right outflow high pressures or pulmonary hypertension. Okay, so personal short axis. Okay, as you can see, heart looks big. This is parasternal long axis, short axis. You have to look at the capillary muscles, and okay, and the heart is not obviously moving well. So you can say that this heart is poorly pumping. You don't need to say the numbers. If you are just a novice or beginner, you can just say that, that's more than enough. Okay, now look at this picture. Look at the septum. This is left ventricle, this is right ventricle, and look at the septum. Okay, the septum looks straight. It doesn't look like round. It looks like this. So it means there is a high pressure system on the right side, which is pushing inward. So that's why it is very important to do echo on patients who have hypotension, unexplained hypotension. I will come back at the end. I'll skip apical 4 chamber. It's kind of difficult to do. But again, the picture is in front of you. This is the right heart, this is the left heart, this is right atrium, this is left atrium. I'll skip that. Now, let me come back to the subcostal view. This is the one that I really want to talk about. How do we know that this is subcostal? The one way of knowing that, once you put the probe on the subcostal area, of course, and then this is the liver, that if you see whatever right next to the liver is right ventricle. So that's how you will recognize that this is right ventricle. And what you see, the fluid around the right ventricle, is pericardial effusion. So let's see if I can make it run one more time. Okay, and you can see that there is an inward motion of the right ventricular wall, and you can see the left ventricle is completely emptying. This is hyperdynamic heart. You can easily get that image in most of the patients who are on the ventilator. Okay, again, this is the subcostal view, and You see right next to the liver, this is right ventricle, this is left ventricle, and you can see the globular heart. And as you can see that as compared to the previous one, the walls are not coming close to it. Okay, I'll come back to IVC. IVC, there's a lot of data about it, its accuracy, when it is useful, when it is not useful. I'll just say one thing, majority of the patients who are on the ventilator, as the data has shown, they do not have pulmonary hypertension because of vasoplagia. Only 20% of the patients, they are reported to have high pulmonary pressure. So it makes us use IVC because it would not be falsely high. You'll see in my experience that I've checked, IVC was very useful because one, they are paralyzed, so it makes the responsiveness of the IVC very visible. Number two is when you do the PLR, passive leg raise, you would see the responsiveness of the IVC from small to big. And majority of the patients, they are dry anyway. So let's discuss about this is the proximal portion. As you can see, the pointer is this way, the heart is this way. This is the inferior vena cava, and let's play it out. And you can see that this is a IVC with high variation, okay? And you measure at the level just a centimeter below the heart. This is how you do the M mode. You measure max minus minimum divided by max. That's how you measure the IVC variation. Okay, so which patients need echo? And this is what I wanted to discuss. Number one, anyone who's on vasopressor needs echo. Okay, so if someone who is not on vasopressor, you can skip it because it's not very easy to do echo on patients. Number two, patients with high SOFA score, because you want to make sure that these patients do not have RV strain. You want to look at the septum. You want to make sure that these patients do not have CHF. As you all know that majority of patients who are elderly, they have coronary artery disease and history of hypertension. That makes perfect sense to do echo. And the highest mortality, as we all know, that patients who are more than 60. So echo becomes part and parcel to do it on these patients. And number three, like I said, you would like to see in a hypertensive patient that you want to give volume, but in patients who have ARDS, you would like to be careful with fluid resuscitation. So that's where you need to do PLR that would show you the responsiveness. You give the volume if they are responsive. Now, this is the last slide. Let's discuss that. I hope I have time. Okay. Now, we did echo in about 12 patients. Have done more than 20 echoes. Only 2 patients I've found that they have depressed LV function. Majority they do not have. They have in fact hyperdynamic heart. I did not see RV dilation in any of them. I did not see any signs of pulmonary hypertension. Their wall motion in those 2 patients were more sort of globular rather than segmental wall motion. That made me think that these patients may have myocarditis. Our patients, 6 out of 7, all of them, they were on the vasopressors. We intubated only 2 types of patients, even if they have hypoxia. One, patients who have signs of hypoperfusion, decreased urine output with decreased brain perfusion and high lactate and high CO2 cap, or patients who have low GCS. Otherwise, we just keep them off the vent because, as you all know, that these patients typically do not do. So we are not the one who do early intubation. So our inpatient mortality in our hospital is about 28 to 30% altogether. Typically, non-COVID cases, if someone whose pulse ox is 85 or 80, we intubate on 100% oxygen, like PF ratio is less than 50. But what we decide based upon the resources, living in Pakistan, we can face dire consequences of our supply chain, as we have heard from Italy. So we opted for those type of patients who have these 2 conditions. And so we can debate about it, but this is based upon the Pakistani experience that I can share with you. We found 3 cases of DVT at the bedside. Actually, I found those cases, and we put them on 1 milligram per kg Q12 hour doses of enoxaparin. So that's when we used the full dosing. And in one case, even though there was no evidence of DVT, we used 1 milligram per kg dose because this patient had refractory hypoxia. So we used that, and it was very difficult to do CT scan because of the refractory hypoxia. So that's when we do that. I did one pleural tap on someone who had right-sided pleural effusion. I'm sorry, left-sided pleural effusion. So that's when the lung ultrasound was useful. Venous Doppler is easy to do. In 22 cases, only 3 cases we found. So our DVT incidence is lower in my experience in our population as compared to Caucasians. So that is what I've noticed. And in terms of IVC, our team has done on all of them, especially if we are giving volume. We do PLR, we look at the arterial line and IVC, and we check the IVC at the subcostal, and we check the M mode, and that's how we do it. We did not do 4-chamber. I did on patients, but I do not recommend that because it's difficult to do. And I have done EPSS, which is averaging around 0.5 to 0.6 E-point systolic excursion. So that's what I wanted to share. Please ask me questions if you have. I'll finish it. Thank you.
All right, thank you, Dr. Iqbal. This was a very informative, and you covered the basics very well. And Dr. Iqbal has a passion with critical care ultrasonography. He has done a lot of courses and has taught a lot of people. And although I attended one of those courses as an instructor, but I ended up learning a lot from you. So, mashallah, thank you so much once again, Dr. Iqbal. So we'll just go over briefly some of the questions we have. And since, Dr. Fakir has been nice enough कि वो हमारा कब से इंतज़ार कर रहे हैं कि हम उनको क्वेश्चंस प्रेजेंट करें. So thank you so much, Dr. Fakir. I'll just go over some of the questions जो मुझे यहाँ पे नज़र आ रहे हैं, and just give me a couple of seconds. डिस्कनेक्ट कर दीजिए. मैंने तो नहीं डिस्कनेक्ट किया. डिस्कनेक्ट. क्वेश्चंस. Okay, so अच्छा जी, सबसे पहले क्वेश्चन जो डॉक्टर फाकिर के लिए है, here we go. There's a question from an anonymous user, Dr. Fakir, and the question is higher tidal volume average. I guess they want to know, okay, what's your average quote unquote higher tidal volume?
आपको आवाज आ रही है?
बिल्कुल, we can hear you. बिल्कुल आवाज आ रही है.
So what I have been using is लेकिन मुझे अपनी आवाज वापस क्यों आ रही है?
हमें आ रही है.
Okay. Maybe I should just, what should I do? I don't know. But what I have been using is, as I already told you in my presentation, that after doing the recruitment maneuver, we actually know what is the optimal PEEP, and we also know that what is the allowed tidal volumes at a higher inflection point, from where the compliance gets poorer. So that's how we basically use the same method, and we'll end up in these COVID patients we'll end up giving like 9, 10 or 11 ml per kg even. So round about like 600 ml, 570, 650 even. So it depends, like because uh, I have been using the plateau of less than 27, less than 28 in most of my patients. So although I have to compromise on the driving pressures, but this is what uh, what what is used by us most of the time.
Good. Thank you. So rough average आपने कहा कि tidal volume 550 से 600 के आसपास. So second, just to a lot of the times हम अपने लिहाज से जब बात करते हैं तो हम ठीक ही बात कर रहे होते हैं being intensivist, but in case non-intensivist हमें सुन रहे हो कि a lot of the times you also have to take the height of the patient into account. Tidal volume of 600 may not be much for me. I'm a little above 6, like in a tidal volume of 600 may be a lot for somebody who's 5'4" or 5'3". Lekin average, Dr. Fakir ne hमें बता दिया कि he's very comfortable going up to these ranges. So, and again, this is average, और हो सकता है.
It's like 9 to 11 ml. That's what I was telling. That
9 to 11.
yeah. So ये predicted body weight या ideal body weight जो आप height के साथ even आपको ventilator calculate करके दे देता है. आप उसमें अगर gender वो डालें तो.
जबरदस्त. Thank you so much. So ये question हो गया. Now, second question is range of PEEP. I assume वो पूछना चाह रहे हैं कि आपने highest PEEP कहाँ से कहाँ तक की है, क्योंकि lowest, as we all know, कि most of the times हम पाँच को ही सही start करते हैं, most of us, आंखें बंद करके. लेकिन ये कि what's your range of PEEP? So I guess जितना आप समझ सकें इस question को हमें बताइए.
If you allow me, I can share the screen and show you a half-a-minute video, if you allow.
उस पे मैं IT से बात कर लेता हूँ, उसको अरेंज करें इस दौरान. ये आपकी स्क्रीन शेयर हो रही है, मेरा ख्याल है.
स्क्रीन शेयर हो रही है ना, बस सही
हो रही है, बिल्कुल.
अगर मेरी स्क्रीन शेयर हो रही है तो कोई प्रॉब्लम ही नहीं रह जाती. I have no, not this one. अभी बताता हूँ. असल में ये क्वेश्चन को एड्रेस होना चाहिए, लेकिन मैं थोड़ा सा उसको साइंटिफिकली बताना चाहता हूँ. ये एक छोटी सी वीडियो है, अगर आपको नजर आ रही है तो मैं
बिल्कुल
बता देता हूँ.
बिल्कुल नजर आ रही है. यस,
ठीक है. ओके, आई जस्ट स्टॉप इट. So this is our recruitment maneuver that has been started. The patient is sedated and paralyzed. Definitely, the patient has got a difficult ventilation and oxygenation. That's why the patient is on 100% FiO2. So after achieving the complete sedation and paralysis, we just start the maneuver, and you can see in this video that the starting PEEP is 5, and we are ending the PEEP at 9. The end PEEP, and the maximum pressure that will be achieved is 35, whatever the volume is reached. At the same time, there is no pause at the end of the PEEP. So now if we start it, you can just, so this is automatically the machine is doing the maneuver, and as there is no pause, so the come down. Just a few seconds more. That's it. So here you can actually see तो यहाँ पे हमारे जो रेस्पिरेटरी थेरेपिस्ट हैं वो हमें बता रहे हैं कि आपको आपकी कितनी ऑप्टिमल पीप होती है, जिससे कि बेस्ट कंप्लाइंस आपको मिल रही होती है. सो इस तरह से आपको एक लोअर इन्फ्लेक्शन पॉइंट या ऑप्टिमल पीप का अंदाजा हो जाता है. एट द सेम टाइम जब आप कर्सर 2 पे जाके और उसको मैनिपुलेट करते हैं, so you actually know that at the 25 centimeters of water, what is the volume that you actually can give. तो अब यहाँ से ये कम करना शुरू कर रही है। और अगर आप देखें कि जब ये प्रेशर्स जो आपको राइट साइड ऑफ द स्क्रीन पे यहाँ पर नजर आ रहे हैं, ये 34 चल रहे हैं, ठीक है, और वॉल्यूम 630 चल रहा है। तो अभी आप कम करना शुरू करेंगे तो वी जस्ट वांट टू सी एट 25 कितना वॉल्यूम आप दे सकते हैं पेशेंट को। तो इससे आपको ये 25 के ऊपर तकरीबन 375 का वॉल्यूम बन रहा है। So what actually I want to say is that, you know, this is quite scientific and you know, इस मेथड को अगर हम यूज़ कर रहे हैं तो बहुत आसानी के साथ हम ये प्रिडिक्ट कर सकते हैं कि आपकी ऑप्टिमल पीप क्या होगी और आपको कितने वॉल्यूम्स देने हैं। और एट द सेम टाइम जब हम इसकी एक पीप सेट कर देते हैं तो उसके बाद फिर हम कंप्लायंस, प्लेटो प्रेशर और ड्राइविंग प्रेशर्स देखते हैं और उसके बाद फिर हम 1 by 1 अपनी पीप को कम करते जाते हैं, ठीक है। सो व्हेन वी स्टार्ट डिक्रीजिंग द पीप, फॉर एग्जांपल अगर हमने पीप 14 की थी, ठीक है ना, जो ऑप्टिमल पीप थी, हमने 14 की पीप थी, प्लेटो प्रेशर्स हमारे पास 28 के या 30 के आ रहे थे। 14 से अगर हम 13 की पीप करते हैं और प्लेटो प्रेशर 30 से कम होके 25 पे आ जाते हैं, ठीक है, इट मीन्स दैट द ड्राइविंग प्रेशर्स इम्प्रूव and you didn't actually need that much of PEEP, so the compliance does improve. So on each patient, you know, you have to spend a lot of time and to just get a good PEEP. लेकिन जो सवाल है उसका जवाब ये है कि ज़्यादातर पेशेंट्स में हमारे जो कोरोना वायरस के साथ आते हैं उनमें ऑप्टिमल PEEP 5 to 8 या 5 ज़्यादा से ज़्यादा 9 तक आ रही होती है। इससे ज़्यादा की PEEP मैंने बहुत कम दी है। और कुछ पेशेंट्स होंगे जिसमें 14-15 की पीप की ज़रूरत थी, उनको दी है डेफिनेटली लो वॉल्यूम्स के साथ। जो कन्वेंशनल मेथड है 4 to 6 ml per kg टाइडल वॉल्यूम, हाई पीप, हाई रेट, सेडेशन, पैरालिसिस, yes, but not a lot of patients. Most of the patients had better lungs, although the lungs were totally white, but strangely enough हमें compliance अच्छी मिली उनकी जब हमने उनको रिक्रूट किया था।
All right, thank you, Dr. Fakar. Last question for you is any experience of using bi-level, या जिसको हम APRV mode कहते हैं? I assume वो आपका
हमने APRV
के अंदर का experience मांग रहे हैं।
हम लोगों ने APRV यूज किया। एक्चुअली माय ट्रेनिंग वाज ऑन वॉल्यूम असिस्ट कंट्रोल, ठीक है, जब मैंने शुरू किया था 2006-7 में, जब तो मेरी ट्रेनिंग शुरू में वही थी। उससे पहले PSB मोड चल रहा होता था, प्रेशर कंट्रोल मोड था, लेकिन मुझे जिसने ट्रेन किया उसने वॉल्यूम AC सिखाया। And then definitely we did use this APRV in our patients with ARDS, but the problem which I could not handle properly was high carbon dioxide. So they do accumulate a lot of carbon dioxide. They have very good मीन एयरवे प्रेशर्स हम लोग बहुत अच्छे मेंटेन कर लेते हैं, हम बहुत अच्छी ऑक्सीजनेशन करा लेते हैं उससे, लेकिन फिर CO2 जब 100 से ऊपर पहुंचती है तो डर लगता है और उसके बाद फिर हम लोग को वापस जाना पड़ता है अपने बेसिक्स के ऊपर। तो मैं सिर्फ ये कहता हूँ कि जिसके ऊपर आपकी कमांड है, जिस मोड पे, जिस पे बहुत अच्छा सा जानते हैं, क्योंकि आप बहुत ज़्यादा दफ़ा ICU में जा नहीं पाते। आप एक दफ़ा गए, 3-4 घंटे आप रुके, बाहर आए, फिर पूरी डॉनिंग करके और वापस जाना, तो अच्छा ही होता है कि आप जाके एक दफ़ा सेट करके आ जाएं, चाहे वो APRV मोड है, वॉल्यूम असिस्ट कंट्रोल है, जो भी मोड है, और उसके बाद आप उसको अच्छा टाइम दें पेशेंट को, तो दे डू कम बैक।
All right, thank you. So you're right, APRV में CO2 को उड़ाना बहुत ही मुश्किल है। Great mode for oxygenation though. तो लेकिन जैसा डॉक्टर फाकर ने कहा कि एक दफ़ा CO2 ऊपर आनी शुरू हो जाए तो दिस मे नॉट बी द बेस्ट मोड। और सेकंड बात आपकी बड़ी इंपॉर्टेंट है, समटाइम्स वी फॉरगेट कि बाकी आम ICU में तो आदमी बार बार अंदर बाहर चला जाता है, लेकिन कोविड ICU में डॉनिंग, डॉफिंग, it becomes quite expensive. Every trip can become very expensive. Yes. And time consuming. So thank you, Dr. Fakar. I think we really don't have any other question so far, लेकिन आपकी talk भी काफ़ी मकबूल थी, तो you never know कि कोई question बाद में आ जाए। Next I have Dr. Rehan. He will be answering a few questions related to Montelukast and I think steroids. And then we will try to get in touch with Dr. Faisal and Dr. Salman. There are some questions for them as well. So give us a sec, Dr. Rehan will be on with you now.
So जी 3 questions हैं, तो actually all 3 are pretty close to heart. पहला है कि मोंटेलुकास्ट का कोई रोल है या नहीं. तो जो मोंटेलुकास्ट है वो साइटोनाइल ल्यूकोट्राइन रिसेप्टर एंटागोनिस्ट है और इसका तकरीबन 8 पेपर्स हैं जो कि इसकी एविडेंस शो करते हैं इन किड्स और SARS-1, मर्स, लेकिन कोविड में इसका सिर्फ इन विट्रो है कि ये वायरल प्रोटीएज को बाइंड करता है. सो इट एक्ट्स एट अ वेरी अर्ली लेवल जहाँ पे ये बाइंडिंग प्रिवेंट कर सकता है. दूसरा, मार्क्ड एंटी इंफ्लेमेटरी रिस्पॉन्स है और ब्रेडिकाइनिन पाथवे को भी इनहिबिट कर रहा है और उसके साथ साथ ल्यूकोट्राइन और उसको भी इनहिबिट कर रहा है. हमारे पेशेंट्स में हमने ये देखा है कि CRP और फेरेटिन हाई डोज ऑफ मोंटी देने के बाद नीचे आ गए हैं विदाउट इवन यूज ऑफ टॉसिन. तो इट्स जस्ट एब्सोल्युटली ब्रिलियंट. और अगर ये काम, इसके ऊपर हमने स्टडी प्रोटोकॉल लिखा है और इंशाल्लाह ताला नेक्स्ट वीक हम लोग इसको लॉन्च कर रहे हैं और कोशिश करेंगे कि ये मल्टी सेंटर हो. तो आप में से जो लोग इसमें शामिल होना चाहते हैं, मोर देन वेलकम. और हम लोग हाई डोज यूज़ करेंगे. प्रोटोकॉल जब आएगा और जब हम उसको अपनी IRB से करके अप्रूव करके जब हम मल्टी यूज़ पे आएंगे तो स्क्रीन हैज़ चेंज्ड. कैन दे हियर मी? तो काइंडली ये चेक करें ये मुझे हेयर कर सकते हैं या नहीं. स्क्रीन चेंज हुई है. बिलाल, स्क्रीन हैज़ चेंज्ड. कैन दे हियर मी? Screen has changed. Can we hear? Well, अच्छा. So it is very effective. So that's montelukast, but inshallah there is no absolute clear evidence at the moment. But it is a drug which has got minimal side effects on all the organs. The only one boxed warning is of idiosyncratic suicidal ideation, but the patients that it is being given to are in the hospital. And if you do plan to give it home or want to take it, please monitor the patients, especially if they are old or have a known history of depression. Second question to me was that anticoagulation in stable COVID patients. So I guess this is comes to the story that I was trying to allude to during my presentation as well, that all of us from north to the south of Pakistan, we have got families who are infected now, some of them with COVID. And for example, we've got a 70-year-old uncle who is actually infected at the moment with COVID. He's obese, he's diabetic, he's got ischemic heart disease. So his risk profile is male, high risk, at risk of severe COVID. Now, in such a patient, how to do a D-dimer? And if the D-dimer is resolved, start him on to anticoagulation. Now, if that patient doesn't want to go on to injectables like a milligram per kilogram of Clexane, then what one could do is that we could give them rivaroxaban at prophylactic or therapeutic dose, depending on the D-dimer. This approach, I think, is way more safer than not giving anything. We, as a Cancer Institute, use a lot of prophylactic Clexane or rivaroxaban, and we haven't seen many complications at all. The platelet count does not reduce down. The platelet count only goes down in 5% of the patients, and most of the people actually have thrombocytosis rather than cytopenia. The APTT remains normal as well, so hence I think that we should actually do anticoagulate them if the D-dimer is high. The last question to me was steroids in stable pregnant COVID patient. Now, I don't, at the moment I'm working in a cancer ICU. I'm also an emergency physician and intensivist, but I am not working in a pregnancy related unit. From what I know of, is that the steroid, if you divide the high risk pregnancy into 2 parts, between 23 to 34 weeks, there is a grade 1A evidence for steroids. So, as in any other high-risk pregnancy, because we do know from the studies in SARS-1 that there is IUGR, there is fetal complications, there is fibrin deposition onto the subchorionic membrane, and that you cannot just leave it as such to chance. Hence, steroids does improve mortality by 50% in neonatal sepsis, necrotizing enterocolitis, intraventricular hemorrhages, and respiratory distress, and improve lung maturation. Hence, do give steroids if they are above 23 weeks. Now, the question comes that if they are absolutely near term, then probably it's best to deliver. Whether to give steroids before delivery or after delivery, that is absolutely up to you. I don't think it makes much of a difference because they are all matured already. But between 23 weeks and term, personal opinion is to give steroids. There is not much of a study at the moment, or neither one could be done in such a scenario that you would get an absolute answer. But because we know already from obstetric guidelines, there is a grade 1A evidence for steroids in high-risk pregnancy above 23 weeks. So do give it because it is absolute sort of a misnomer that why wouldn't you? Because you've got already high-risk pregnancy. You already do know that between 23 and 34 you have to give. So why not to give? Over to you. Is it Dr. Fakir's turn now or Dr. Faisal? Yeah, Dr. Bilal.
Hi, Assalamualaikum. Thank you, Dr. Rehan. I'm sure everyone is finding this very helpful. Next we have Dr. Faisal Shamim. अगर उन्होंने हमें join कर लिया तो हम video पे उनसे कर लेते हैं. Otherwise he's on at audio as well. Let me find your question. Sorry, ये थोड़ा सा time लगेगा. जी डॉक्टर फैसल आपके लिए स्पेसिफिक क्वेश्चन है if we do have specific equipment for positioning not available यानी कहने का मकसद है कि equipment अगर available नहीं है और patient is not tolerating proning, is there any other position preferred or has benefit?
Okay, so Rehan, can you hear me?
Yes, we can hear you, Dr. Faisal.
Okay, so yes, the important thing is, which I think is thanks for the question, and so I think the person who has asked, but this needs to understand that lying on prone or lying on the belly is a part of repositioning and conscious prone repositioning. Other position you may assume, but that will not benefit the patient. So ultimate goal is to assist, to ask and request the patient to turn on belly. Now, if you go or if you, I can share the picture. If you can share the picture which I showed in the presentation, that shows no additional equipment, just pillows, and you can ask for you can request the patient to turn on the belly for 30 minutes to 2 hours, assess that whether the patient is tolerating or not. I think that is very mandatory to turn on the belly and then turn on the right side or left side, and then after 2 hours sit up, head up, sit up in the bed, and then continue with the repositioning to the cycle. The cycle should be completed. The point is that the prone positioning, awake prone positioning, will help you in homogeneous ventilation and making a good VQ mismatch, a reduction in the VQ mismatch. The heart will be free and more independent. So these all sort of the benefit which comes the prone positioning. It will not come with the positioning right lateral or left lateral. Right lateral and left lateral are part of prone process, but that will not replace the lying on belly or prone awake proning.
Thank you so much, Dr. Faisal. Okay. Yes, thank you very much. I think
I hope it's clarified.
Yeah, it does. And thank you very much once again for coming back online with us.
Thank you.
Thank you, Dr. Faisal. Next up we have Dr.
Okay.
Next up we have Dr. Salma, who has a question from Dr. Kamal. I assume, yes, you have the question. So please go ahead.
The question is, I want to know about the treatment trials or the recommendations in COVID positive pregnant ladies. So the first part of the question, so there are no treatment trials for COVID positive pregnant ladies yet. And the second part on treatment, so overall, if you look at the therapies, so what has shown some promise so far, tocilizumab and remdesivir, and what needs to be explored further is convalescent plasma. So of these three, pregnancy is the relative contraindication for tocilizumab, so I wouldn't use that. In the case of remdesivir, FDA says that it has to be a risk-benefit analysis. If the benefit outweighs the risk, obviously they can go ahead and give remdesivir. And then the treatment option that we're left with is convalescent plasma that should be explored further in this population. So we have limited options for all patients, and they're even more limited in the case of pregnant ladies. Thank you.
Next one.
Okay, very good. All right, next question is from Dr. Kamal Noshin. She's actually a consultant in gynae at Sir Gangaram Hospital. So she had a question for Dr. Salma, which she just answered, and now she has a question for Dr. Asma. So please go ahead.
So the question is that, do we have any SOPs for the intubation for the COVID positive patients? So basically, the majority of the management of pregnant patients who are COVID positive doesn't differ from the rest of the population. Taking into consideration the normal physiological changes in pregnancy, I would suggest that if any patient needs intubation, that should be done early, because of the risk of the airway edema, the risk of the aspiration, and also taking into account their low functional residual capacity. And obviously, because of all these factors, the most majority of these patients are anyways intubated with rapid sequence induction, so that should be, that policy should be adopted.
All right. Thank you, Dr. Asma. Excellent question, excellent answer. Thank you very much. Next is, अब थोड़े से सवाल रह गए. All right, Dr. Kamal has a question for Dr. Rehan. तो हाँ, उनको हम देख लेते हैं. Next up is Dr. Ehsan Vakar. कुछ questions इनके लिए भी हैं. तो पहले हम डॉक्टर एहसन वकार से सुन लेते हैं, and then hopefully we will get to the question for Dr. Rehan. All right, so give me a few seconds and Dr. Ehsan will be here. All right, really sorry, I know Jamaica time करीब है और आप लोग wait कर रहे हैं, तो just a few more seconds hopefully. Let me see if we have any other questions. Again, let me reiterate, बहुत सारे questions हैं regarding the availability of the video. इसकी बिल्कुल recording हो रही है. And I think the video should be available from 2 to 5 days, inshallah, STM की website के ऊपर. लेकिन as soon as I get a link, hopefully जो हमारे critical care और pulmonary groups हैं उनमें तो it will be easy to circulate. And और होपफुली इस वेबसाइट को चेक करते रहिएगा SKM की, उसके ऊपर भी हम इसको लगा देंगे इंशाल्लाह. So give us like a week. Now for those of you attendees जिन्हें सर्टिफिकेट वगैरह चाहिए, you do have a window of 2 days, 48 hours है आपके पास, जिसमें आपको आपका e-सर्टिफिकेट भी मिलेगा. एंड डू गिव अस योर फीडबैक. फर्स्ट टाइम हमने ये अटेम्प्ट की है विद such prestigious institutes, SIUT, AKU, Shifa, and we are all very grateful, और PKLI कि इन लोगों ने हमारे साथ इतना अच्छा ताउन किया, despite some of them had technical difficulties, but it was just the camaraderie was amazing. So thank you once again. So if you do have any suggestions, please next time inshallah usko behtar karne ki koshish karenge. What is next? All right, so one of the questions is, can steroids be used for intractable cough? Since I am critical care and pulmonary medicine, तो ये question मैं hijack कर लेता हूँ. I guess it depends the nature of intractable cough care. Sometimes with these COVID-19 patients, after they suffer an infection, चाहे वो minimally symptomatic हो या intubate हो चुके हों ये लोग, sometimes the airway is just very sensitive to any stimuli. And for a patient who may not have had asthma, may act as if he has asthma. Again, इसको bronchial hyperreactivity भी कहते हैं. Some of the patients may benefit from a small dose steroid trial. You could also, I mean, before giving steroids, you just have to make sure कि कुछ और ना चल रहा हो, upper airway cough syndrome ना चल रहा हो, नज़ला अलग से ना हुआ हो, GERD ना हो कि बहुत ज़्यादा तेज़ाबियत की वजह से उनको खांसी हो रही है, हम steroid दे दें और वो ठीक ना हो. So first of all, you have to make sure कि कोई और reason नहीं है, ACE inhibitors पे नहीं है या कुछ कोई और cough की cause ना हो, and then you could give a small dose. Dr. Rehan is working on his question. One of the questions is, what will be the dosage regimen of steroids to be followed between 23 weeks till term? Very specific gynae questions. And I know Dr. Huma Batul from LGH was also. I can answer that right now. Okay. So Dr. Huma Batul ka bhi ek question hai. So Dr. Rehan will be with us. Huma ke bhi.
अच्छा, ये अभी एक और क्वेश्चन दोबारा उन्होंने इसको फाइनेंस किया कि जी डोज क्या आप देंगे. देखिए जो स्टैंडर्ड डोज दी जाती है ना हाई रिस्क प्रेगनेंसी में अबाउट 23 वीक्स, वो होती है 6 मिलीग्राम डेक्सामेथासोन Q12 आवर्ली फॉर 4 डोजेस. लेकिन उसका जो इंटेंट है वो समझना चाहिए. उस डोज का जो इंटेंट है वो है सेफ्टी ऑफ द फीटस. यहाँ पे जो आपका इंटेंट है वो है सेफ्टी ऑफ द मदर, क्योंकि आप उनको कोविड के लिए ट्रीट कर रहे हैं और उनके बायोलेटरल इन्फिल्ट्रेट्स हैं, वो हाइपोक्सिक हैं और आप उस सिचुएशन में उनको दे रहे हैं. तो उसमें जो मुरवजा डोज इस वक्त जो चल रही है एक नॉन प्रेग्नेंट पेशेंट में, उनको वही डोज देनी चाहिए, विच वुड बी 0.5 to 1 milligram per kg of prednisolone equivalent. ठीक है, तो विच वुड बी इनफ फॉर बोथ ऑफ देम. तो उसमें मेरा नहीं ख्याल कि उसमें कोई तब्दीली करनी चाहिए, क्योंकि जो बेनिफिट है वो हमको पता है कि फीटस को तो बेनिफिट है, और जो नुकसान पॉसिबली हो सकता है वो हो सकता है कि इंड्यूस्ड डायबिटीज, मैक्रोसाइजेस और वो, और उसको फिर आप मॉनिटर कर लें. थैंक यू. Handing it over to Dr. Ahsan.
Assalamu alaikum. So 2 questions for me, I guess. So one of the questions from Dr. Usman Bashir. He wanted to know. Let me see what the actual question was, if I can find it. So in the absence of negative pressure rooms, how can we reduce aerosol generation? So having negative pressure rooms while we are instituting non-invasive ventilation is something which is desirable, but not an essential. So when we talk about control measures, one of them is provision of negative pressure rooms. But if we don't have one, what is essential is having personal protective equipment in place. So that is the most important bit. You must have personal protective equipment in place before you do something else. In low resource setting where there is no negative pressure rooms, obviously you need to have rooms that are reasonably well ventilated. So that is something that you need to remember. Your first option is having negative pressure, but then rooms that are well ventilated, and then moving on from there. The second question that has been asked from me is bi-level ventilation. So that is an interesting one. So here the terminology is confusing, to say the least. Many makes have made different ways of ventilation, providing ventilation at two different levels. Now, two different levels can be defined through pressure, through volume, and some have put their nomenclature as levels. So it's very simple. BiPAP ventilation, bi-level ventilation are not entirely different concepts. So the summary of the matter is that there are two different levels at which patient is allowed to breathe. Some of these ventilators allow them to breathe at inspiratory and expiratory, some of them don't. So that is the only difference really. So the experience of bi-level ventilation, the question was, what is the experience of bi-level ventilation? So the answer is, it must be treated as any other non-invasive ventilation. Thank you very much. I hope it answers the queries. Thanks very much for joining us. I will ask Dr. Bilal to come back and say a few concluding remarks if there are any. So just bear with us a minute, please. Thank you.
Thank you very much, everyone. I know thoda sa hum over our time, but the participation was amazing. And once again, thank you to the speakers, thank you to the attendees. Inshallah, next time we'll try to keep it a little bit short, maybe less ambitious. Definitely there's so much to learn. This is a new disease which we did not encounter, and I'm very proud to say that our Pakistani physicians, and they are at par, they're doing their best. And you've heard some of them today, how they're managing patients in the ICU and even post-extubation care of such patients, which I've never heard this talk on any other webinar. So thank you once again, and a recording will be available. And inshallah, get your e-certificates within the next 48 hours. And hopefully we'll, with your suggestions and your feedback, we'll try to arrange something even better, inshallah. Muhammad Bilal Ashraf, Pulmonary Medicine, Critical Care at Shaukat Khanum Hospital, bidding you farewell. Assalamu alaikum.